morning, everyone. We welcome you all to OrthoTV in association with Mumbai Suburban Orthopaedic Society. And to introduce today's topic and the speakers, I hand over to the Secretary of MSOS, Dr. Satish Mutha.
Thank you, Neeraj. A very good morning to all of you and a warm welcome on behalf of Mumbai Suburban Orthopaedic Society and OrthoTV. Friends, this is the fifth of a series of weekly webinars which have been organized by MSOS over the last 2 months, in which we try and share with you some very pertinent topics of day-to-day practice for general orthopedic surgeons. We have had very interesting webinars on hand surgery, foot, sports medicine, and we have had more than 16 to 1800 viewers each time. Continuing this series, today we have a webinar on an extremely important topic in our day-to-day practice. It's always very difficult when we see a small, crying, cranky child entering into our clinics with a painful limp or a deformity. It perplexes us more often than not where to begin investigations and what is the possible diagnosis. Dr. Mandar Agashe, a prominent pediatric orthopedic surgeon, has set up an excellent faculty today and is going to share with us various topics which are going to be useful for us to evaluate a child that enters our OPD, right from a limp to a deformity to fever and such important things. Mandar, my only request to you, Mandar, would be to share as many points that are pertinent to us in our day-to-day practice and basic investigations and how to streamline our thought processes in such difficult cases. Mandar, I would also like to thank OrthoTV for letting us use their platform so that we can optimize our outreach. And I also wish to thank Janssen who have supported this event. So I now request Mandar to take over the proceedings and start with the...
Thank you very much, sir. It's a great pleasure to invite you all for this webinar on something which was probably not discussed in all the webinars which have already been done, and that is office pediatric orthopedics. Now, office pediatric orthopedics is basically all the cases which we see in our routine clinical practice, not just as pediatric orthopedic surgeons, but as general orthopedic surgeons also. And we'll be dealing more with just the clinical examination of the child, the protocols to be followed, and less on probably the surgical aspects. To set the ball rolling, we have Dr. Swapnil Keny, who's an honorary associate professor and head of the unit at the Sir J.J. Group of Hospitals. He's also a consultant pediatric orthopedic surgeon at the Keny Hospital, Saifi Hospital, Sir H.N. Reliance Hospital, and Zen Hospital. He's going to start off with a very important topic, which is how to examine a small child and how not to make the child cry. Over to you, Swapnil.
Thank you very much, Mandar, for those kind words of introduction. I have been given a very daunting task here. And the reason I'm saying it is daunting is not only because this lecture was very difficult to prepare because everyone has a different perspective, but also because of the fact that it is daunting to examine a child in your clinic without making the child cry. So I'm going to share some tips and tricks which I have learned over the last 15 to 20 years with the hope that it will make all of us a little more wiser in trying to understand the psyche of children who come to us and also help us to streamline the process of examination so that we can reach a diagnosis when a child walks into our OPD. So trust me, whenever a child walks into the OPD, it is a war. And this has been reiterated by many of my colleagues who've told me that, "Arey, wo bachcha aaya, wo bachcha ro raha tha." And then it was such a complete mess to examine that child. And all of us have gone through this. The pediatric orthopedic surgeons have, of course, need to live with it because it is a part of their daily bread and butter. But for others, to make matters simple, one really needs to understand that these children, though look very, very harmless, carry such an arsenal with them that you don't really know what you're dealing with. So my job here is not only to prevent you from being a hostage into that situation, but also to equip you with the necessary armamentarium so that you can examine these children without maximum collateral damage. So the root of the problem essentially starts from the year 1975, the year which I was born, when Gabbar Singh came on screen and said that 50-50 कोस दूर जब कोई बच्चा रोता है तो माँ कहती है कि बेटे सो जा वरना गब्बर सिंह आ जाएगा. Similarly, our parents have been teaching children and telling children, or rather they have been mortifying children with the threat that if they do not behave themselves, then they will be taken to a doctor who will be giving them an injection. And the threat of this injection is such that it remains with the children till they grow up and realize that the treatment for every ailment is not an injection. So hence starts this reign of terror in the minds of those children. And it is so difficult to deal with it. Now, in the 2nd century, a famous Chinese general by the name of Sun Tzu wrote a book called as The Art of War. And dealing with these children is nothing less than executing all the principles which Sun Tzu has told us. And before you actually start to execute these principles, you need to classify this opponent. Now, why I'm saying opponent is because, believe me, the child coming into your OPD is really a formidable adversary. And unless you know how to deal with this adversary, you cannot take your examination forward. So essentially, there are 3 kinds of opponents or 3 kinds of children you need to face: the debutants, the pinch hitters, and the accomplished veterans. All the 3 terminologies taken from the game of cricket, which is very, very popular and very dear to all of us. So the debutant is usually a very young child, comes for the first consultation, is extremely naive and walks very curiously into the consultation room. But he has been sensitized to the injection threat, remember that. So the moment you put this child on the examination couch, the child will start to cry. And these are the most tricky to examine. The next is the pinch hitter. Now these children are slightly more experienced, have been primed by previous visits, so they know that the moment they enter the consultation room, there is a threat. They are totally reluctant to lie down. They have a very aggressive demeanor. They turn around, kick, jump, and try to escape. And these are the most difficult to examine. The third are the accomplished veterans, the slightly older children who are between 4 to 6 years of age. They are fiercely independent and moody. They have realized that not every visit to the doctor means an injection, but sometimes it can. Many of them, thankfully to us, are gadget dependent, may cry, but are definitely pacifiable by parents. Parents have by now learned how to pacify this child, and they are the most easy to examine. Now, Sun Tzu has actually told us in all the chapters written in his book about the principles of dealing with a formidable adversary. And the same principles have to be followed when you're dealing with a child, which include laying plans, waging war, attack by strategy, tactical disposition, the use of energy, weak points and strong points, maneuvering, variation of tactics, army on the march, terrain, attack by fire, and the use of spies. Now, the first thing is that you should have a clutter-free environment always. It has to be clean, colorful, and comfortable. 3 most important C's. You need to distract the child so that you can examine this child very, very easily. The second point is waging war. And here you have to remember that most important, however aggressive and agitated the child is, you need to maintain your composition. So clear compos mentis, especially for those who have been under these pressure situations, is not difficult. But for the younger generation of pediatric orthopedic surgeons or general orthopedic surgeons, you need to maintain your composition, because if you lose your temper or you're angry, it really projects you in a very, very low light in front of the parents and the relatives. So calm, composed, and controlled is what you need to be. You need to have a particular strategy of attack. And this strategy is essentially by placing toys. Smaller toys you can place in the proximity near your table to lure the child. The larger toys can be placed on the examination couch, which act as a smoke screen, so the child is distracted when you are examining the child. And you can keep balls of different sizes to check the gait. So the moment you roll the ball and ask the child to walk behind the ball or run behind the ball, you can actually check the gait of this child. Tactical dispositions extremely important. However, your aims may be to examine this child, but you should appear totally harmless. Keep both your hands visible to the child so that he believes that you do not have an injection in the hand. Be extremely slow, no jerky movements, no sudden movements, no abnormal movements. Be very, very slow and patient when you examine this child. The use of energy, it is best to examine a child who's sleeping, who's de-energized. If the child is not willing to sleep or has just got up, you can actually ask the parents to pin the pelvis of the child, and this is the easiest way the child can be examined for lower limb examination. And you can pin the other limb when you're examining a particular limb of the child. Then you can swiftly turn the child around so that you can examine the child in prone while the parent is pinning down the child at the PSIs. Every child has a weak point, and most of the weak points are chocolates. These are essentially a Brahmastra, but do not squander them. Just when the child comes, don't give him the chocolate, You have to give him the carrot when it is required. So do not squander your chocolates. Use them judiciously, and they should be given as a reward for good behavior. Maneuvering, the next step, is extremely important. Here you need to distract the child with the help of gadgets, but do not ever give your own phone, because many of us carry high-end phones which are our lifeline, and in case the child decides to throw the phone down, and if there is a problem, nobody's going to pay you for that. So distraction is a big advantage to examine the child, and this is very, very important when you're applying and cutting plasters, because the machine, the noise which the machine makes can be really scary to the child. So try and use this when you're cutting plasters and casts. Sometimes you need to vary your tactics, especially when there are children with special needs. Color and music may be appealing. Battery operated toys and winding toys may be useful. And you can also give the child some sort of a creative activity when you're examining this child. The family on the march. Now this is the biggest problem which all of us face as pediatric orthopedic surgeons. Not only the parents, grandparents, uncles and aunts, everybody can just barge into your office, and you need to strongly dissuade such practices. Have only the child and the parents. There are some parents, especially working parents, who may carry an older and a younger sibling. And this particular sibling can actually possess and can actually cause another set of challenges. So try and see to it that this sibling is always kept out somehow. Either you can ask your assistant to take care of the child, or you can ask the mother and get the father inside. But for any particular reason, do not allow the sibling, because it is a complete source of distraction for you as well as the patient. The next thing is you have to have a particular way and manner in which the child becomes comfortable. So it is best to examine the child in the parent's lap. A parent sitting by the child acts as an additional safety net, and children are much more comfortable. This is especially true when you're examining a child who's injured. Attack by fire has to be used very, very judiciously and carefully. Sometimes it's the carrot, sometimes it's the stick. This is the only way you can deal with unruly children. I'm sorry to say this, but this is actually true. You need to appear stern in your demeanor, not in your words. You need to resort to domination in your actions by not speaking anything, but instilling a fear of doubt in this child. Appear unrelenting and dogmatic in your actions. Do not relent to the threat of this child. Sometimes just a voice modulation, where you change the pitch of your voice, can be a very, very useful arsenal in your armamentarium. You can somehow use spies, and these spies can be very, very important and helpful to you in examining children. It is a universal fact that children trust women more than men. So try and have a lady assistant or a nurse, because the children get a feeling, maternal feeling, when they are around a lady. Once this confidence is established, it is sometimes easy to examine children. Some specific tips and tricks before I end this lecture. Very, very important again. Minimal touch is important. and it works best. This is especially true when the child is young. For the pinch hitter, you need to act ignorant at first and just observe the child, let them do what you want or what they want. You remember the pinch hitter actually is the most difficult child to examine. Once they do what they want, then you can pin the child down so that the child can be examined. And this is the way the child needs to be pinned to the pelvis. It really makes the child immobile and you can examine the child easily. The special child, you can use gadgets, distract the child, and when the child is distracted, because usually many of these children have reduced mobility, then when you distract the child and they are not cranky, you can examine them. And for the accomplished veteran, you need to build a rapport by speaking to them, asking them how they are, cracking a joke, giving them a toy. And once that is done, you can examine these children. So to end my talk for today, success is not only the fruit of labor, but in young children and trying to examine them, it is the fruit of intense, labor-intensive efforts and actions. Thank you very much.
Thank you very much, Swapnil. That was an excellent lecture on one of the most practical issues which we deal with, examining a child. I would like to now invite Dr. Sandeep Vaidya. Sandeep Vaidya is a consultant at the Pinnacle Hospital. He's a consultant orthopedic surgeon, pediatric orthopedic surgeon. He's also a visiting consultant at the Jupiter Hospital and an honorary consultant at the Vijay Hospital. His talk for today is another common topic, which is bow legs and knock knees, how to make sense of them. Over to you, Sandeep.
Thanks, Mandar. So I am speaking on one of the most commonest pediatric orthopedic conditions that we see in the OPD, and that is bow legs and knock knees. So I will be talking about differentiation of physiological deformities from pathological deformities, following which I will touch upon clinical assessment and very briefly about the radiological assessment of bow legs and knock knees. Right? So first and foremost, the most important point is how do you differentiate whether a given deformity is physiological or pathological? And for that, this graph, all of you are well acquainted with this. And this gives the progression of the thigh leg angle, the physiological thigh leg angle from birth to skeletal maturity. And we know that when a child is born, he's born with natural bow legs. This bow legs gradually starts correcting in the second year of life as the child starts walking. It reaches an angle of 0, that is the legs completely straighten out sometime between the age of 2 to 3 years. From where onwards, the legs start going outwards into the position of knock knees, reaches a peak knock knees at the age of around 4 years, and then again starts coming in and reaches an adult valgus angle of around 6 degrees by the age of 8 years. So with this knowledge of physiological progression of the thigh leg angle, we know that both these cases, this is a 15-month-old boy with bilateral bow legs on the left-hand side and a 4.4 years boy with bilateral knock knees on the right side. Both of these are physiological deformities. Nothing needs to be done. They just need to be kept under observation. And indeed, when you follow them up, you see that they completely correct on their own. So what is pathological? So once we know what is physiological, whatever does not fit into the physiological limits is obviously pathological. So what are these conditions? Let's see one by one. So if the deformity exceeds the normal physiological limit, so this is a child who is 2.5 years old, but obviously the deformity is much greater than what you would expect in the physiological bow legs, and therefore definitely this is pathological. And on evaluation, this turned out to be a case of X-linked hypophosphatemic rickets. Deformity persisting beyond a certain physiological age. So here is another boy, a 5-year-old boy with physiological with bow legs. However, he's 5 years old, and we know that physiological bow legs does not persist beyond the age of 3 years. So obviously this is pathological, and on evaluation, this turned out to be a case of metaphyseal chondrodysplasia. Asymmetrical deformity is always a red flag sign for pathological deformity. So this was a child who presented with bow legs, but only on the left side. And therefore, this is not physiological, this is pathological. On X-ray evaluation, this child showed the classical radiological features of Blount's disease. Again, asymmetrical deformity, a windswept deformity, that is a bow legs on one side and knock knees on the other side, is almost always pathological. So this was a windswept deformity, which was a skeletal dysplasia in this particular case. If there is an underlying skeletal dysplasia and the deformity is severe, obviously we know that this is a pathological deformity. This is not going to resolve. In this particular case, this was a child with Morque's syndrome, classical short trunk dwarfism, and this required treatment. Again, another child with achondroplasia, and here you can see that there was a bilateral bolex, and since the child was achondroplasic, we knew that this was pathological and needed to be corrected. This is one of the commonest conditions that we see in our country, that is, bolex or knock knees occurring secondary to nutritional rickets. And indeed, in this child, when we did the X-rays, there were signs of florid rickets. He was just treated with calcium and vitamin D supplementation, with which his calcium and vitamin D levels came to normal. And in case of deformity secondary to nutritional rickets, you must allow for spontaneous remodeling, because especially in the younger children, most of them resolve on their own once the metabolic parameters are corrected. However, in resistant metabolic conditions, like in this particular case, this was a case of renal osteodystrophy, we know that just simple metabolic or medical management is not going to help in correction of the deformity, and therefore these are pathological deformities, need to be corrected. Finally, if there is a past history of trauma or infection, then that should be one of the red flag signs to look for an associated physeal growth disturbance. So in this particular child, there was a history of infection in childhood. On evaluation, it was obvious that he had a physeal bar, which was causing a progressive genu-valgum deformity, and therefore treatment of this deformity requires correction of not only the deformity, but also addressing the physeal bar. Then coming to clinical assessment, how do you assess the bolex and knock knees deformity? So the first test that I would do when a small child, probably an infant or a toddler, comes in with a physiological bolex is the cover test. And this is a test which is specifically designed to differentiate between physiological bolex versus Blount's disease. So what is the cover test? It's a very simple test. So here what we do is we cover the lower 2/3 of the leg with a pillow or a draw sheet, and we observe the alignment of the knee. If the alignment of the knee continues to be in varus, then it indicates that this is not a physiological bolex. This can be a Blount's disease, as is seen in the child on the right. On the other hand, you can see that in the child on the left, the alignment of the knee is actually in valgus, which shows that this is a physiological bolex and not a Blount's disease. Next, what is the severity of the deformity? So that we have to document. And here we calculate the thigh leg angle by measuring the angle between the ASIS and the patella center, and the patella center and the ankle center. However, while measuring this angle, care has to be taken that the patella has to face forwards. Having measured the severity of the deformity, we are interested in knowing what is the location of the deformity. So a genu-valgum deformity or a genu-varum deformity can occur due to the deformity occurring either in the femur or in the tibia. In this particular case examples, in the example on the left, you can see that the deformity is in the distal femur, whereas in the case on the right, the deformity is in the tibia. So how do we differentiate which is which? So here we do the simple test, which is known as the knee flexion test, where we flex the knee. And if the deformity disappears on flexion of the knee, it indicates that the deformity is in the femur. However, if the deformity persists on flexing the knee, then the deformity is in the tibia. Is the deformity progressing or resolving? For this, we measure the intercondylar distance in case of bolex and intermalleolar distance in case of knock knees, and serial measurement of this distance over a period of time tells us whether this deformity is progressively worsening or whether it is resolving. Finally, I will briefly touch upon radiological assessment. And once it is decided that we need to do a surgical management of a particular deformity, it is very important to obtain full-length standing radiographs. These radiographs must be weight-bearing. One particular point of importance of these radiographs is that they should be done with the patella facing forwards. For example, in this particular case example, you can see a radiograph which has been obtained. However, as you can clearly see, there is an overlap of the proximal tibia and fibula, which indicates that this is an X-ray taken in rotation. So the second X-ray is taken with the patella facing forwards, which clearly shows the severity of the deformity. And here is the actual clinical picture. So very important that your X-ray should be done with the patella facing forwards. Finally, you should be aware of the radiological changes of the pathognomonic radiological changes of certain specific pathologies. So Blount's disease, it progresses from a stage of metaphyseal translucency to the frank changes, epiphyseal, physeal, and metaphyseal changes in stage B. And finally, there is a physeal bar which occurs in stage C. Also, this is a very rare condition called focal fibrocartilaginous defect, in which there is a defect on the medial aspect of the proximal tibial metaphysis. So this is a specific condition, a specific pathology called focal fibrocartilaginous defect, which should be differentiated from Blount's disease because the treatment considerations for the two are different. So to conclude, in any given bow legs or knock knees deformity, differentiate physiological from pathological. In clinical assessment, we have to assess the magnitude, level of deformity and progression, and always obtain good quality appropriate radiographs if you are to do a surgical correction. Thank you so much for your kind patient hearing.
Thank you very much, Sandeep. That was an excellent overview of a very common condition, which is bow legs and knock knees. Our next speaker for today is Dr. Tushar Agrawal, who is a consultant pediatric orthopedic surgeon. He has his own hospital, Asta Hospital at Kandivali. He's also an honorary consultant at the MGM Kamote Hospital. And he'll again be talking to you about a very important topic, which is in-toeing, out-toeing, and flat foot. A thing which so often patients present to us. And I'm sure Dr. Tushar Agrawal will give us an excellent overview of the same. Over to you, Dr. Tushar.
Okay, am I visible and audible?
Yes, sir.
Yeah, okay, great. Good morning, all of you all. So, my take today is to talk on in-toeing, out-toeing, and flat foot. So now let's go to one of the most common causes of in-toeing. So you are going to be presented with a video which resembles this. So if you look carefully on the left side of this video, the child was in-toeing. So the patients would be most commonly presenting to you like this. They'll come between 18 months to 5 years. The parents would be very concerned. One of the parents probably is convinced that it's a waste of a time to meet us because it's a non-painful condition. However, lots of neighbors and relatives have started commenting on the in-toeing, so they are coming to meet us. And occasionally they complain of the fact that there is frequent falls. So looking back on what Sandeep Vaidya told you, so you want to rule out, you want to do a cover test, and you rule out that there are any bowed legs here. So there is a straight trajectory from the thigh. However, you flip the child over and you see that the thigh foot axis is not neutral. So this is the long axis of the thigh and the foot is not in line with it, but facing inwards. So which leads us to believe that this has a tibial intorsion. For documentation, you may choose to do an X-ray, though this appears to be a benign condition. And I must tell you that up to 3 years of age, you can probably do the X-ray in your clinic. After that, it's better to refer them to an X-ray clinic which has a software for doing a scanogram. And for the younger kids, you may do a supine scanogram. And for the older kids, it's better to opt for a standing scanogram. And all scanograms should be done with the patella facing neutral, so that which can be verified by the entire fibula being visible on your scanogram. Even for your clinical checking, what this appears as a bowed legs, once you actually bring both the patella forwards, resembles more of a tibial intorsion. So this is a very, very important test that you have to do, is that the patella, the legs have to be neutral and the patella should be facing skywards when you're looking for bowed legs. And actually then the tibial intorsion is actually unveiled. Then also you ask for W sitting. So this was another child with in-toeing. However, the child had a relatively normal thigh foot axis, but is a W sitter. So a W sitter means more femoral anteversion. Similarly, this kind of a child will have more femoral anteversion, but is not able to sit cross-legged, right? So what am I trying to tell you here is that there are two types of situation at the hip. One is the hyperlax, second is the structural. So the hyperlax will have increased internal rotation as well as external rotation, and the structural will have an increased internal rotation with a decreased external rotation at the hip. And lastly, you want to look at the foot. with the metatarsus adductus. So femoral anteversion is always a combination, various permutation combination of femoral anteversion, tibial intorsion, and metatarsus adductus. We need to know that the metatarsus adductus resolves by 3 years of age, the tibial intorsion naturally resolves by 6 years of age, and the femoral anteversion will resolve by 10 years of age. So before 10, we would not want to do any surgical intervention if we are suspecting a sort of a non-resolving in-towing gait. And if at all there is any surgery which is advised, it is for FAI, that is acetabular impingement, which leads to anterior thigh or hip pain or anterior knee pain. Now let's look at some pathological causes of in-towing. So this is a patient with obesity, with a pre-Blount's kind of a disease, with a Perthes on the opposite side. Okay, now the other pathological in-towing is a cerebral palsy patient. So you can see from the front and the back, this is gross in-towing, right? And this is a very interesting situation which resembles an in-towing, but it's a developmental condition and which is visible on the scanogram that the patient actually has a genu valgum, okay, which is manifesting. So here if we treat the genu valgum, then probably the entire in-towing will be corrected. That's why a standing scanogram is so important. So what to do? So if you have intorsion, so first you rule out whether it's idiopathic or pathological. And if it's pathological, you rule out neurological, developmental, non-resolving variety, rule out obesity, Blount's, pre-Blount's. And for that, you take a detailed history, birth, milestones, who's noticed this first, who's continuing to notice it, whether it is increasing, resolving, whether there are any functional problems, whether it's unilateral, bilateral, and whether the child is a WCT. And on clinical exam, always remember to flip the child prone, do a thigh-foot axis, check for hip rotations, do cover test, as Sandeep had said, look at the foot and do your scanogram. So what not to do? So do not scare the parents, never miss a pathology, don't do unnecessary investigations, and never do unnecessary splinting. Now let's look at some cases of out-towing. So this was a newborn child who had initially presented to me, born with bilateral out-towing, and he had bilateral IT band tightness. Another child who had come with a foot deformity, and he actually had a calcaneovalgoid foot. So that was a congenital cause of out-towing. Now you look at the left side on both the videos, okay? And look at the fact that the child is feeling clumsy. So there is a left side out-towing here. So here we checked the patient and actually we discovered that the popliteal angle. So you keep the opposite leg straight and you do an SLR, which should be actually resembling this on the normal side, but the patient has a restricted popliteal angle. So what are left infantile hemiplegia? We are discussing the out-towings. So this is a more grown-up child. You look more on the right side as compared to the left side. And he still requires help for staircase climbing and descending. And actually the child is 5 years of age. So once you are roughly 5 years of age, you should be able to negotiate stair climbing and descending on your own. So that's also a very important test which you need to do in patients of out-towing. So this patient had developmental delay along with hyperlaxity. So hyperlaxity is something which we really need to check by recurvatum at knee, the thumb touching the volar aspect of the forearm, the wrist dorsiflexion, and the hyperflexion of the little finger and of the elbow. So what do we do in out-towing? We rule out whether it's a benign condition with hyperlaxity and hypotonia, or whether it's syndromic, neurological, or the child has genuine congenital or ataxic conditions. And you look for walking, getting up from the floor, and stair climbing. What not to do? So do not instill fear in the parents or the child. Don't do a suboptimal evaluation. Evaluate in great detail. Don't miss a diagnosis, and brace very judiciously. Lastly, we come to flat feet. So this is the most common cause of flat feet, which I actually see, whereby the child actually has a limb length discrepancy because of mild hemiatrophy or hemihypertrophy, resulting in pes planus. This is the other common cause. So this is a mild obesity here, okay, slightly high BMI with flat feet. And the lastly, you have a young adult with a painful stiff flat foot, which is actually a peroneal spastic flat foot coming from a tarsal coalition. So how do you look for flexible versus rigid flat foot? Turn the child facing opposite, make the child stand on toes. And if the heels come back to neutral, the flat foot is flexible. And always look higher up because the pes planus may be because of the genu valgum. When you look at a calf hypertrophy, do CPK because occasionally we find that the patient of muscular dystrophies are presenting with flat feet. Now, always do, if you have to do X-rays, always do a standing, single leg standing X-rays. Only then are they valid to check for flat feet. And always remember that patient can have a vertical talus. There are many surgical options available for flat feet only when indicated. So my final thoughts, all these three conditions, intoing, outtoing and pes planus are mostly always benign. You pick up the apparent causes, look for the inapparent causes very carefully. Therapy and reassurance forms the mainstay of most of the time. Rarely orthotics are required and very, very rarely surgery will be required. If it's a unilateral condition and there is associated developmental delay, there's hypertonia and gross hyperlaxity, then it becomes very significant. Thanks a lot.
Thank you, sir. I think the last slide which he has shown works well for almost all conditions in pediatric orthopedics. Most of them are benign conditions. We should pick up the apparent, look for inapparent, have some therapy, rarely orthotics, and very, very rarely surgery. That is the story of every pediatric orthopedic, almost every pediatric orthopedic condition. A related pediatric orthopedic condition will be shared by our next speaker, who is Dr. Atul Bhaskar. He is a consultant pediatric orthopedic surgeon at the Surya Childcare Mumbai and the Bombay Hospital, and he's also an honorary consultant at the Cooper Hospital in Mumbai. So he's now going to talk to you about a related topic, which is about the limping child. It's again a very important topic, and for which a number of referrals come to us. So over to you, Atul, sir.
Yeah, thank you, Mandar. And I think Tushar and Sandeep has covered some of the common conditions where child will present with a limp. So I'll just share some of the other conditions which are common and we should not miss. Can you see the screen?
Not yet, sir.
One second. Let me just go to the. Sorry. Yeah. I can see it now.
Yes, sir. It's just starting.
Yeah. Okay. So common things which we should not miss in practice. So I'll cover some of the basics condition which present to us. So this is a 14-month-old child who comes with a limp, a painless limp. There's no history of any fever, and you can see there is a limp on the right side. Parents are concerned about the gait of the child, and this is not uncommon in our practice where this child is crying and has gone to the pediatricians and they've dismissed the walk because they're in a busy clinic. They can't really assess the child's gait. And this child, lo and behold, had these asymmetrical creases on examination. And if you actually do this is a different child, but when you do a limb length assessment, you will find that the limb on the affected side is shorter. And this is not uncommon to find untreated DDH coming at a walking age, where usually the mother or the caregiver has noticed a limp, and they are quite persistent that the limp has got worse where the child walks. This is not noticeable when the child is not walking, and hence we see many children coming with DDH presenting at this age, which should have been picked up much earlier into practice. Similarly, a child like this, he was 4 years of age, and he came walking like this to the clinic. You can see he had a severe lumbar lordosis. He's got the waddling gait. He had an MRI scan of the spine. He had a neurological evaluation, but nobody did his hip X-rays. And this child actually had a classical bilateral DDH, which was completely missed until age 4, despite having classic signs. And these are bilateral DDH obviously present much later than unilateral DDH. And we recently published our paper where the mean age is almost 2.5 years for bilateral DDH presentation versus unilateral DDH presentation. So these things should not be missed. Any limp in a child, painless limp in a child should always be evaluated. So, it may be apparent in the beginning, but it's worth taking an X-ray at 6 months of the child who's got abnormal limb findings or abnormal gait at 9 months. Do an X-ray, make sure they don't have any hip dysplasia. This is a child, 2-year-old child, started walking at 18 months, normal delivery, and this was his presentation. This again not uncommon, toe walking in a child at 2 years, but you can see he still needs support. So toe walking can be idiopathic, it can be spasticity. They need good evaluation, and you must rule out any neurology. So this child, of course, turned out to be a cerebral palsy with spastic gait and needed passive stretching, AFOs, and physiotherapy. But not all toe walkers are spastic. So sometimes you can have even children with DMDs presenting with as toe walkers. Sometimes it may be idiopathic. So up to age 3, sometimes if there are no hard signs, you can really counsel the parents, and only after 3 years, 4 years, if you feel that the toe walking is not improving, then you can start doing some stretches and you can start giving some splints. But they need an evaluation. Look for hard signs as well. Look for the spine, the other development as well, to make sure they are not missing any neurology. So this was a 2.5-year-old child who came with this gait pattern where there was a big distance between his legs, and Sandeep has covered this very well. So bow legs, parents coming like this, and these children really need evaluation. If they're so severe, one has to evaluate them because there are multiple causes of bow legs, and in this one has to look at the child's stature, whether it is symmetrical, whether it is progressive, and again, you assess the laxity. So this child had achondroplasia, this girl had Brown's disease, this girl had metaphyseal chondrodysplasia. So there are various causes of bow legs, and as the child gets older, they will progress, especially if they are syndromic. So bow legs need evaluation, and Sandeep has very well shown that by 3 years, physiological bow legs will change into valgus. So they need assessment at least up to 3 years. So these are extra for normal child. So this is another child. You can see this child walking with the unilateral bow legs, and as he walks, he's got this classical lateral thrust as he walks, and he's only 2.5 years of age. And this is a classical condition of Brown's disease, where this child had unilateral Brown's disease, and you can see he's got early changes with metaphyseal beaking, and he's beginning to get these early signs. You can see some changes on the opposite side as well, and so these should not be missed. Another history, 2-year-old child, full-term normal delivery, cried soon after birth, started walking at 15 months, and parents noticed something awkward about the child's gait. This is courtesy of Dr. Mollin, and this child was walking with a foot outturned. And you can see this girl walking like this. But Tushar has covered some common causes of outgoing gait. He has mentioned about infant hemiplegia. He mentioned about spasticity, but other things you need to watch for. You can see in slow motion how this leg goes outwards. So there was no history of fever, infection, no joint pain. Child has been very, very playful. X-rays were done. X-rays were completely normal. There was no limb length discrepancy. There was no evidence of hip instability. Of course, it's difficult to assess the muscles at this age. This child, on further evaluation higher up, had a mild atrophy of the thigh, and then you go higher up and you see a sacral dimple. So always examine the child entirely when you find any kind of limp, because you may find subtle signs of spinal dysrhythm, and this child had an ultrasound scan showing a low-lying tethered cord, which was confirmed on the MRI scan. I underwent detethering surgery, and after the surgery, the child's gait improved. And you can see the scar of the surgery there. So this is very important, not to miss unilateral outgoing. They are always usually pathological. Very rarely you'll find outgoing on one side physiological. So you must completely evaluate the child from top to bottom. It could be a hemiplegia, it could be a spinal dysrhythm. So these should not be missed. Going further up, a 7-year-old child with limp since 3 days, no constitutional symptoms, restriction of hip movement. This girl presented in the clinic, and you can see her walk. She's very reluctant to weight bear, and as she walks, she's got this massive limp on the right side. She's painful. So this is a classical antalgic gait, but she was not toxic at all. So this pain brought us to the hospital, and we did some investigations. So she had an ultrasound scan which showed a lot of effusion in the hip joint. Plain X-rays are normal. Her blood counts are normal, and this is classical transient synovitis. But these things must be evaluated, especially if they persist beyond a week. So you want to rule out Perthes in the older child. You want to rule out GRA in the rare conditions, even a sickle cell. So transient synovitis will usually settle down, and all of us know the treatment of that. This is another child. This This is a 7-year-old child walking with limp for 4 months with pain in the left thigh and knee. Yet he had fever more than 100 degrees, but there's no issue of trauma, no other joint swelling. So it's painful, toxic, one-sided pain, an antalgic gait, hip movements are restricted, but there was no thigh and knee tenderness. And this was his clinical finding. His left leg was longer than the right side. Sorry, let me see if I can show his gait. I think it's the same. Yeah, sorry, this is the one. This is the child. Yeah. So this is a child who presented 4 months walking like this. Okay, this is the gait of the child, but this child had fever, was painful as well. And this was the X-ray finding. The X-ray was reported as normal. The MRI showed marrow changes in the neck. So this was diagnosed with osteomyelitis. The child underwent surgery, drilling, but the pain persisted even after the surgery. Child was further referred for higher antibiotics, but there was no improvement. And the CT scan then showed an osteoma. And this was the previous track of the drainage of the osteomyelitis. So this is again not uncommon. Osteoma can mimic osteomyelitis, and child must be evaluated maybe by a specialist who can report the X-rays very well. And they can have florid marrow changes even in osteoma, mimicking an osteomyelitis. And this child underwent CT guided drilling, which was then relieved of his pain. Another older boy, normal milestone, had toe walking at 2 years. At 7 years, difficulty in climbing stairs. Now again, Tushar has showed this. These children should have been picked up at age 2, but at 7 he had difficulty in walking. And this is how he presented in the clinic. And you can see how he's walking again with lordotic gait. These children, you must always perform the Gowers test. Don't miss a diagnosis of DMD. It can be medico-legally painful for you. So this child had a classical sign, was not diagnosed until age 7. The parents, mother had conceived another child by then who also turned out to be Gowers. So this should not be missed. So early signs are toe walking or difficulty in climbing stairs very, very early. And they must be picked up, I think, before 4 years so that at least they can be counseled and started treatment. So he had dystrophin gene confirmation, high CPK levels. This is another child, 4.5-month-old child, not taking weight on the right leg, no issue of trauma and fever. Sorry, I'll just show the X-ray. Yeah. So painful but non-toxic. This child was retracting the leg as you touch it. There was swelling on the tibia, no local warmth, but there's a bowing deformity on the tibial side, and this was the finding. The child was not moving the leg very well, and further up, this child also had these cafe spots. So these are again very, very typical of neurofibromatosis, and his X-ray showed 1 month prior. This was the X-ray, and then he actually had a fracture as the parents were making him stand, and he started crying because of pain. And this is what is a diagnosis of congenital pseudoarthrosis. So again, it should be picked up very early so that at least we can counsel them and start early splinting. And this child underwent then rodding of his tibia. Now this child had a fracture. He was 3 years old, treated in a Thomas splint. But when they came to us, once the plaster was removed, when the spica was removed, the child walked like this in the clinic. And you can see his marked intoeing gait with marked femoral intorsion. And the parents were concerned about this walking pattern. Now he actually had a post-traumatic deformity, and his CT scan confirmed a mal-rotated femoral shaft fracture where there was 90-degree intorsion, and he underwent a derotation osteotomy. So again, be careful evaluating a child with a limb. Ask for history of any injuries in the past, any treatment in the past, which will reveal the cause of the limb. This is a 12-year-old child, overweight, limping for 3 weeks. Presented to the clinic, and you can see he's got this. He looks really overweight, 80 kgs, having the right side limp for 3 weeks. Was having difficulty in squatting, and this again is a condition which should not be missed. Is a slip capital femoral epiphysis, and you can see he's got a slip on the right side, which needs early pinning. Otherwise, this will progress, leading to a complete separation of the epiphysis. So this again should not be missed. So this is another child, similarly 85 kg, 12 years old child. So these are not uncommon in practice now. You suspect any older adolescent child with overweight, he had knee pain and restricted hip movement, think of a slip. So this child again had a slip on the left side and underwent a pinning. So these are very common conditions now we are seeing in practice because of the kind of meta-obesity seeing in the community. And this is the pinning. So lastly, I don't want to miss the back pain as well. It is rare in children, commonly because of poor posture, but it can be a source of pain and limp. So any back pain persisting beyond 3 weeks needs evaluation. So don't just look at the legs. You must examine the back and do a thorough neurological examination. So this child was limping when he came to us. He had hamstring tightness, and you can see he had a slip. He had L5S1 listhesis, which required surgery. So this is again a common condition. They walk with this kyphotic gait pattern, and you should not miss a slip. So he was an adolescent boy. So again, approach to a child with a limp. Make sure whether it's painful or painless, whether it's bilateral or unilateral. Tushar has already covered these, and Sandeep has covered these conditions, but don't miss these as well. So unilateral DDH, Perthes, hemiplegia should not be missed at all. Painful whether they are toxic or non-toxic. So we see a lot of synovitis, but again, stable slip capital, toddler's fracture will fall into this gamut, and toxic, of course, infection and tumor. So that should be like an approach to a child with the limp. And again, with following with Dr. Swapnil, Keny, the anxiety has to be allayed, and you should make sure the child is quiet before you can examine them. And some of them will need an urgent referral. So thank you very much for giving me this opportunity, Dr. Mandar, and for sharing this talk.
Thank you, sir. Excellent talk as always, sir. There are just a few questions coming on OrthoTV. First is to Dr. Swapnil. The question is, if you want to do an intervention like giving a plaster or something, so how are you going to manage? So do you keep the parents in the room or on the lap, or the child is on the lap of the parents, or how do you manage?
So the thing is, you need to first evaluate what sort of a child you're dealing with. Now, if it's really a very, very young child who is likely to be cranky and likely to kick you, then you have to have the parent along. If the child is really a neonate where you're applying a CTV cast, then as you know that in the mother's lap it is the best way to apply it. If you feel that the child is cooperative, then what you can do is you can have the parents in the room, but have the child seated in a comfortable position with some sort of a distraction like a mobile phone, and you can just first assure the child that it is not going to be a painful procedure. If you're cutting a plaster, what you should do is you should start the plaster machine and actually run the blade on your own skin and show that it doesn't harm. You have to assure the parents as well that this plaster cutting machine is not going to cut the arm of the child. So this is a game of reassurances, and it is also a game of choosing. So there is no defined formula, but you need to decide on a case-to-case basis.
Absolutely. Great advice, Dr. Swapnil. Next question is to Dr. Tushar Agrawal about the role of bracing, or many fancy braces are there for flat feet, about medial arch supports or SMOs. So what do you use them in practice, and what are the indications, if any?
So if I have seen a patient and I'm convinced that it's a benign, flexible flat foot, I try to dissuade the parents from using any form of bracing. That is the first thing. However, if they look a little disillusioned by my talk, then I ask them further, is the child falling a lot? Are you disturbed by the wear of the footwear? What is the exact nature of the functional problem? And then maybe you can give an SMO or some form of a convenient brace, and then see whether there is a reversal of that problem. So, you may be wrong in the first place, and there will be a reversal of problem. For a brief while, they may be happy using the brace, but they should understand that there is never going to be a reversal of flat foot by using the brace. They may solve some of their functional problems, not the primary condition.
Great. So last question is there for Dr. Sandeep Vaidya about to do a scanogram. What are the indications? Do you always do a scanogram when you see a child with bow legs, and especially in a small child, it's very difficult to get even a supine scanogram. So how do you manage to do scanograms in small kids?
No, firstly, scanogram is not indicated in every case. I would do a scanogram only in cases where I am planning a surgical intervention.
Okay.
So anyways, these are mostly the older kids. They are not the smaller kids. Okay. And here, we should make a bit of a differentiation between the terminology. So scanogram is typically what is done in the lying down position, in the supine position, whereas standing weight bearing radiographs is what would be, of higher, value in terms of, surgical planning. And that is called a teleröntgenography rather than a scanogram. So, And it is usually required in the older children. I would reserve it only for children who are going for surgical intervention.
Absolutely. Next section, we have two very interesting talks. We'll have the lecture by Dr. Rujuta Mehta in after these two talks. So we have two very interesting talks by two invited faculties. So the invited faculties are those who are not pediatric orthopedic surgeons, but who are basically the go-to persons for us. And the first is Dr. Vijay Vishwanathan. He is a pediatric rheumatologist. He has a postdoctoral fellowship in pediatric rheumatology. He's one of the very, very well-published pediatric rheumatologists. And if I have ever a doubt about any joint pain in a child, Vijay's phone is the one whom I always call. And we have a detailed discussion about the patient before sending as well as after he sees the child. So he's going to talk to us about joint pain in kids, how to manage, how not to miss the important ones. Over to you, Dr. Vijay. Dr. Vijay, I think you have to unmute yourself.
Yeah. Am I audible and visible?
Yes. Perfect.
Thanks, Mandar, for the kind introduction and also introducing me to the group of elite orthopedicians in the city. And I've been given this enviable job of finishing my job in 15 minutes. And I am happy to know that most of the orthos are fond of cricket. So what I'm going to show you is a bit of a power play of cases, which in a busy bone OPD, once in a while, you might end up seeing a joint and you may get a bit stumped. And there are certain golden rules which if you follow, you would probably never go wrong. So these are three common situations which will come to any of the pediatric OPD, but most likely they will be coming to an ortho OPD also. So the first one will be a 5-year-old girl with a history of fever, rash, a common cold-like scenario about a couple of weeks back. And 2 weeks later, the child comes with a painful swelling of a knee joint. And when you investigate this child, most of the tests will be normal. The ESR would be mildly high, but the child is relatively non-toxic. And if you do a CRP, it is negative. The other will be classically a 11-year-old boy who comes with a progressive swelling of the lower extremity of the joint, and he may start adding up more joints, but then you all often notice that the child has a bit of a redness of his eyes. And on a detailed history, this child would probably have a history of a food poisoning or a dysentery about 4 weeks back. And when you examine, this child has a conjunctivitis or a corneal opacity along with the arthritis. So the first situation is the most obvious one. It is a post-infectious or a post-viral arthritis, whereas the second one is a condition called as Reiter syndrome. Remember Reiter syndrome as an acute form of a HLA-B27 associated arthritis, commonly following a Shigella infection. The transient synovitis of the hip, I will probably skip because most of us are pretty well versed as far as transient synovitis of the hip is concerned. But if this child behaves a bit unusually in the sense it's not responding the way it should be, the only thing which probably would come to a mind is rule out a Perthes-like story. A very specific form of a post-infectious arthritis will be a 12-year-old girl who presents with high fever, a red tongue, and a tonsil which is loaded with follicles. As difficult as it might be, when you have an acute arthritis in a febrile child, I might request all of you to just have a look into the mouth, see the tonsils, if it's showing follicles, and she presents within a week with a painful additive swelling of knees, ankles, wrists, and small joints of the feet. And as with habit, this we would be sending an ASO titer with the tonsillitis. And the condition is not rheumatic fever, but it's a classical condition called as a post-streptococcal reactive arthritis. So the most common reasons for an acute arthritis in an OPD setting is a post-infectious or a reactive arthritis, usually follows an infectious prodrome. Lower extremity joints are most common. It could be oligoarticular or polyarticular. The classical history of morning stiffness should not be missed. A morning stiffness often tells you the inflammatory nature of the problem. And typically, these are children who will have more of pain and less of swelling in the relative context. And many of them are self-limiting, or you just need to give a short course of an NSAIDs. No need for any hi-fi testing. If at all, you would be very selective in your testing, like the ASO titer. This is a kid who I will skip very fast because this is orthopedician's bread and butter. A 5-year-old girl with high fever, single swollen knee joint with a history of pyodermas, eczema since early infancy. And this is a hot, swollen, painful joint with high counts and high acute phase markers. No prizes for guessing. This is septic arthritis or osteomyelitis. The only request will be that for some reason I have stopped seeing routine synovial fluid being tested for cell count, because the rheumatology literature says a cell count more than 50,000 is often suggestive of a infective pathology. We may have the occasional enthesitis or a JIA with 150,000 counts, but what is certainly a bit disheartening for me is when I don't see a routine microscopy with the known fact that the cultures may be sterile in about a third of cases. So, and the only message that I would like to reinforce is, which I do with the pediatrician, is you may have a sterile effusion in a knee osteomyelitis. And if when it comes to the hip, the synovium is being a large synovium, when you have a septic arthritis of the hip, always consider a possibility of a underlying osteomyelitis. This is another situation where a child might come with acute arthritis and it is a nightmare. A 4-year-old boy with low-grade fevers, excessive sweating, and 2 or 3 joints. And the classical morning stiffness will not be existent. This is a child who will be extremely irritable, so much so that the sleep will be disturbed more in the nights. And this child, when you examine, he will be pale and there will be significant bone tenderness. And this is a picture which I commonly use to convince pediatrician that when you have an articular problem, you will see a synovium jutting out, whereas the other side, as we know, is a periarticular swelling. A periarticular where the whole dorsum seems to be swollen, and this child will limp, or the kid on the left will limp in the morning, the kid on the right will probably have a lot of nocturnal symptoms. And when you do a CBC, please do not ignore the low counts. By low counts, I mean less than 5,000 is low for me. And remember to see the differential. A 3,400 with an 82% lymphocytes. A platelet less than 2 lakh is low for me, and a 3-digit ESR. So when the ESR and platelets go in opposite direction with a high lymphocyte count in a child who has nocturnal pains, please think of a leukemia in evolution. And this will not be difficult, but the issue is convincing yourself to send an ESR. So what are the red flag signs? A red flag sign is a sick child, whereas most of the acute arthritis or a post-infectious kids are happy. Periarticular pain, a bit of pallor, organomegaly, high lymphocytes, ESR platelets going in opposite direction. And always remember, a 3-digit ESR is always a problem. Please do not start steroids. Having said that, try to think of rheumatology once in the morning before you start your OPD, because you may end up seeing a child with henoch-Schönlein purpura like lesions who may present with arthritis, a young child who's running fever with red lips and having arthritis. You may eventually diagnose him as Kawasaki disease. We have seen cases of muscular dystrophy discussed, but juvenile dermatomyositis can also present with arthritis. And if you notice muscle wasting and the positive Gower sign, you will start thinking of possibly idiopathic inflammatory myositis. And when you see arthritis with such gory infarcts and gangrene, obviously the diagnosis of vasculitis. So rheumatology does present in an ortho OPD also. Not so infrequent condition will be a 2-year-old male child who walks with a right knee joint swelling since 1 year of age. And remember that a joint which recurs and starts at age 1 with a significant family history is almost always shouting hemophilia as a diagnosis. And sometimes if you're too aggressive and insert a needle and you aspirate out blood, we know that synovial hemangiomas or PVNS can also present like a hemarthrosis like picture. Now, we go to a chronic arthritis. Chronic arthritis is probably what most of us will be seeing in the OPD. And this will be the classical, sorry for this, a 1 to 5-year-old child, I'm sorry, a 1 to 5-year-old child, less than 5 joints, with morning stiffness. The child will not be toxic at all. And when you examine, the child will have a normal acute phase. Mandar, just give me a minute. Hello? Hello? Hello?
Yeah, we are hearing you.
Yeah, Mandar, just a minute. I think it's gone on autopilot.
Vijay, we can hear you.
Yeah, the slides are getting transitioned a bit fast. So
Okay.
just give me a minute.
No problem.
So when it comes to a chronic arthritis, this is the commonest scenario in the OPD. You will have a 1 to 5-year-old child with swelling of large and small joints. Usually the number is less than 4. And then usually it's a girl more than a boy. And there will be a classical history of morning stiffness which will be elicited. And when you investigate the child, everything will be normal except the platelets, which will be slightly on the higher side. And remember, when the platelets are on the higher side with a normal hemoglobin, the commonest cause is inflammation. And the CRP will be negative, ESR will not be very high. And this is a child who will look like this. The classical 1 to 5-year-old is a child who will be diagnosed as a juvenile oligoarthritis. And this is a child where only an ANA needs to be checked, and the ANA will be strongly positive. Remember, when you have a young child, ANA to be checked by and it should be checked by indirect immunofluorescence. When this child starts adding up joints, and this is a condition called as juvenile oligoarticular. So when you have less than 4 joints, you will diagnose oligoarticular. And when the child starts adding up more joints over a 6-month period, the diagnosis becomes oligoextended, JI. And the only test that you need to do in these children is an ANA. And once the child becomes polyarticular, you start throwing in a rheumatoid factor. So what are the clues and how do I interpret? When the age is less, number of joints are less, females more than males, acute phase markers are less, you diagnose oligoarticular, and this will be confirmed with an ANA positivity. And unlike the acute arthritis where the pain is more than the swelling, these are situations where the swelling is more than the pain. And obviously the child will be happily limping except for terminal stiffness. This is a classical situation of juvenile oligoarticular JI. Now, these two kids are presented with an oligoarticular presentation. Both are 3-year-old, one is a female, one is a male. Both have come with right knee, both have morning stiffness. The kid on the right seems to have low-grade fevers, which are undocumented. And both the kids have inflammatory counts in the form of a high platelet count. ESR is 30 in the left, ESR is 80 in the right. And ESR, along with the ESR, the ANA, obviously we send an ANA when the age is less, number of joints are less. ANA on the left side is 1 in 320, whereas the ANA in the right side is 1 in 100. So which one of this is juvenile oligoarthritis? The kid on the left is the classical JIA. The positive titers of ANA is 1 in 160. The kid on the right has a bit of a red flag in the form of a high ESR. Remember, when you see a single joint with a high ESR, although the age and the inflammation and the pattern fits in JIA, I would be very concerned about this ESR of 80. And if it's a short history, rule out septic arthritis. If it's going on for 4 to 6 weeks, start thinking in terms of tuberculosis before starting treatment on of juvenile arthritis. From the 2-year, you start moving to a 12-year-old girl. And this is a 12-year-old girl who presents with symmetrical and asymmetrical and or asymmetrical joints, large joints and small joints. And when you examine this child will be normal. And So a 12-year-old girl who walks in with a symmetrical large and small joints and occasional constitutional features, and again the history of morning stiffness will be elicited, and ESR will be normal or mildly high, platelets will be high. And the classical symmetry that you will see, large and small joints, temporomandibular joints. So what are the clues? It's so from a 2-year-old with oligoarticular, a 12-year-old will have a polyarticular disease. More than 5 joints, females more than males. Morning stiffness again will tell you that this child has inflammation. And this is an age where you will throw in a rheumatoid factor along with the ANA. ANA because an adolescent girl has all the reasons to have a lupus-like disorder. And RA because of rheumatoid arthritis. And anti-CCP seems to be a specific marker for erosive disease. And this is a situation where you will not do a HLA B27 by any chance. This is sometimes I do get orthopedic cases in my OPD. This was a child who was referred with a large and small joint swelling, and he was a 10-year-old boy. And the symptoms of stiffness was non-existent. Child was normal at birth, and the child started having slight contractures of his fingers from the age of 4. And this is how he looked like. And he was obviously short for a 10-year-old, and it looked like a short trunk dwarfism. But there was extreme symmetry. Even the best of polyarticular JIs will not be so symmetrical. And the clinical clue was this child never had any stiffness, and his acute phase markers were very normal. So you order a skeletal survey and end up diagnosing spondyloepiphyseal dysplasia tarda, or what is called as pseudo-rheumatoid dysplasia in our textbook. So sometimes skeletal dysplasias can masquerade as polyarticular JIA. The last few cases, this is a child who will walk in the OPD with high-grade quotidian fever and arthritis and very high inflammatory markers. This is a child who will have a hemoglobin of 7, white cells of 25,000, extremely high platelets, 3-digit ESRs, and ferritin is high. And if you see fever with rash with arthritis, you will end up diagnosing systemic arthritis. I'm extremely sorry for this. So So a child who presents with high-grade quotidian fever with a rash and evidence of ongoing inflammation in the form of high neutrophilic leukocytosis, high platelet count, a high ESR, occasionally might end up in the OPD. Before thinking of any infectious process, you will diagnose a systemic arthritis. The last situation that most of us will encounter is a 10-year-old boy. And this is what I normally get to see from Mandar, is a 10-year-old boy who keeps limping since 2 months. And this is a child who will come from the UP Bihar belt, morning stiffness, absolutely normal counts, or sometimes you may have a severe explosive count. And this child will have a ESR which can be either normal or it can be very high. So this is a classical situation where you will never do an ANA or a rheumatoid factor. You will only send a HLA B27 and document enthesitis or dactylitis or enthesitis related arthritis. So why is it important? Because this is a child who had ankle and evidence of sacroiliitis. And when you start treating this child, and this was going on for 6 months with the current age therapy, this is the same child after a couple of biologics. This is a child who's completely different, and the enthesitis seems to have disappeared from the MRI also. So a 10-year-old boy who comes with such a presentation, think of HLA-B27 and nothing else. So what are the clues? We've talked about it. The last of the JIA group is, I promise this is the last slide. Uh, a 3.5-year-old child who will be who will be presenting to your OPD with, uh, who looks, we now know that a 3-year-old with a single joint is oligoarticular. And this is a child who starts adding up a finger. So adds up a dactylitis. And then we will, after about 6 years, this child actually had psoriatic arthritis. So recognizing patterns early is important. And when an oligoarticular child keeps having dactylitis, you will think of a psoriatic arthritis. The last 1 minute of my talk is to just show out some mimics which look like rheumatology, which look like orthopedics, but then end up in my OPD. A 14-year-old girl. Now we know that a 14-year-old girl is all the reasons to have polyarticular disease or a lupus-like disorder. But the first question, that the only question which will be asked is a morning stiffness. The child doesn't have morning stiffness. And all the blood tests are essentially normal. But the pediatrician diagnosed her as polyarticular juvenile arthritis. And because of the good response to naproxen, get started on methotrexate. And then after 2 weeks, the naproxen gets stopped and the pain recurs back. And everything seems to be normal, but there is severe pain. And the logical problem is that we would end up doing vitamin D levels, which will come low. And remember, vitamin D is a common reason. And I don't need to educate orthopedicians for vitamin D. The paradox is I saw one more kid on the same day who was a 12-year-old female, again with increased pain in the joints. And this time, again, no morning stiffness. Meets an orthopedician, gets 6 packs of vitamin D once a week, mild improvement, but then the pain worsens, goes to the pediatrician with abdominal pain and constipation. The pediatrician doesn't see the ortho prescription and advises 5 more vitamin D. The medical shop hands 10 sachets. And because it's a South Indian Tam Bram family like us, he gives the whole sachet. So as it turned out, this child had taken 15 doses of vitamin D, coming to a total of 12 lakh international units. And remember the age-old saying, stones, bones, groans, and psychic moans. All the abdominal pain, constipation, and the joint pains were thanks to vitamin D. And I did a vitamin D level, which came as 250 nanograms, and it was almost on the verge of creating an iatrogenic renal failure of sorts. So remember to be very careful when you order a vitamin D and make sure that you censor the dose at 6 weeks. So, and the last thing I would like to end is by showing a case which in Swapnil's language could be a debutant, pinch hitter and veteran at 3 different occasions, but he may be a pinch hitter and a veteran and a debutant with one pediatrician or one ortho also. This was a 15-year-old boy who weighed 90 kgs and he had severe polyarthritis, extremely sick looking, and he had traversed the whole of the western suburb of Mumbai and ended up with me in Navi Mumbai. And he had lots of imagings, NCVs, EMGs, bone marrows, ganglion injections, angiograms, pregabalin, amitriptyline, steroids, and something sinister seemed to be happening. And like the previous speakers, we just decided to stop everything, observe, take a detailed history, and I'm just setting up uh, a background for a further talk sometime at some point of time, because these are kids who are regularly referred to me by the orthopedicians. And with this, with the detailed history, it turned out that this child did not have any major things happening. And if Mandar sends me this kid, I call it malingering or mandingering. If Sandeep sends me this kid, I call it Sandeepwat. If Taral Nagda sends it to me, I call it Taralismus. But the glamorous word that we use is a pain amplification syndrome or a diffuse amplified musculoskeletal pain syndrome. This is a child who had a lot of trouble with academics, and there were a lot of issues happening in the family, and it needed just an extra hour of counseling and talking and listening to the parents and putting them on to the physiotherapist, as I call them, or the physiotherapist. And over a period of time, this is the same boy. This is the same boy who started uh, exercising regularly, and the anxiety. So sometimes the rheumatologist plays the role of a counselor also. an orthopedician also, a rheumatologist also, and sometimes you just have to stop all the medicines to get this child back onto track. So these are a few case scenarios I wanted to share with all of you. And the take-home messages from this is acute arthritis, mostly viral, post-infectious, more of pain, less of swelling, reactive rheumatic fever, septic arthritis, malignancies, commonest differentials for them. A chronic inflammatory arthritis usually is a happily limping child, more of swelling, less of pain with morning stiffness. Recognize patterns, the age, gender, number of joints, etc. Judicious use of tests, and please don't use steroids without confirmation. And as far as chronicity is concerned, a young age is less, number of joints are less, acute phase markers are less, oligo GI confirmed with ANA. When this extends to more than 4 joints, you call it oligo extended. An adolescent female, a 12-year-old with large and small joints, acute phase markers are high, polyarticular confirmed with RF and CCP. An adolescent male, UP, Bihar, belt, lower extremity joints with dactylitis or sacroiliitis, call it enthesitis, confirmed with a B27, always to be done by PCR. And when you see the occasional child with high fever and rash, with high ferritin, high inflammatory markers, think of a possible systemic arthritis. So when all the joints look the same, it becomes a bit difficult as a rheumatologist to decipher, but with a little bit of opening up of the brain and a careful recognition of patterns, life becomes easy. Thank you for the kind attention, and sorry for the mishaps in between.
Thank you, Vijay. That was an excellent overview of everything we can miss when we are treating certain joint pains in kids. I'm going to invite the next talk with by Dr. Chetan Anchan. Before I do that, just one quick question. Vijay, I'm going to put you in a spot by asking you that before we send you the patient, should we do any investigations? Or we should just let you do whatever you want? Should we do any blood investigations?
So the answer is reversed. You would probably not do a few things, and you are allowed to do a few things. It's only because each of the antibody costs about 800 to 1200 rupees. So most likely in an acute scenario, as we discussed, you will probably only do a CBC, ESR, a CRP, and SGPT and a creatinine, because many of them might need to be put on naproxen for a longer period of time. So you make sure that the liver and kidneys are normal. But if you sense a pattern, once the child crosses 4 weeks and the child has a joint, and then you recognize the pattern, a 2-year-old, you will do an ANA, a 12-year-old, you will do a rheumatoid factor, a 12-year-old male, you will do an HLA-B27. That is all that is probably expected. And just remember that ANA by immunofluorescence in a 2-year-old female, rheumatoid factor in a 12-year-old female, and HLA-B27 in a 12-year-old male with lower extremities. Beyond that, I don't think you need to investigate any further, and leave some things for me to think about.
Thank you, Vijay. Great talk. So I'm going to call the next invited speaker, Dr. Chetan Anchan, who is a consultant orthopedic oncosurgeon attached to Bombay Hospital, Jupiter Hospital, and the Sir H.N. Reliance Hospital. He has a special interest in malignant bone tumors in children. And again, whenever we see a child who has a suspicious lesion in the bone, Dr. Chetan's phone is the number which I always call up. And he's going to talk to us about a very common thing which presents to us, which is a hole in the bone, that is cystic lesions of the bone in children. Over to you, Dr. Chetan.
Thank you. Thank you, Mandar. Is my screen visible?
Yes, sir.
1 second. Okay, here we go. Thank you, Mandar, for this kind invitation and your very kind introduction. I'll be talking about hole in the bone, evaluation and management of cystic lesions of bone in children. Before I start, I acknowledge several of the cases shown here are courtesy of my dear friend and eminent bone tumor surgeon from Ahmedabad, Dr. Shah. Some of my cases include that have been managed in collaboration with pediatric orthopedic surgeon friends of mine, and Dr. Tushar Agrawal, Dr. Vijay, to name a few. I thank all of them for sharing their experience and expertise with me and permitting me to share these cases in this presentation.
Dr. Chetan, can you come ahead a bit? Voice is slightly less.
Okay, I am using this. Is it better?
Yes, better.
Okay. So There are several lesions of bone that may appear like cysts on the X-ray. Many of these are seen in the immature skeleton. If we go strictly by the definition of a cyst, a growth consisting primarily of a fluid or a blood-filled space, there are only two well-known cystic pathologies that can manifest in the pediatric skeleton. In fact, they manifest primarily in the pediatric skeleton. That is simple bone cyst, or also known as a unicameral bone cyst, SBC or UBC for short, or primary aneurysmal bone cyst, which is well known as ABC. Now, ABC, we also should know that there is something called a secondary ABC, which can be seen as a part of other bone tumors like chondroblastoma, GCT, osteosarcoma, etc. Now, as a cyst is fluid-filled space which has replaced the normal bone, it appears like a lytic lesion on the X-ray, the so-called hole in the bone. However, we should know that there are also few other bone conditions which are not really cysts but can appear like holes in the bone. Therefore, it is very important that you don't dive into any of these holes without knowing more about them. So what are the questions that you should ask when you see a patient with a hole in the bone in your OPD? The first and foremost thing is, why was the X-ray ordered, whether by you or anybody else? So was there a complaint of pain or swelling in the region? Whether this patient had a similar complaint or history in the past? Or was it done for any history of injury to rule out any sort of bone damage? Well, if it was for a history of injury and on that you saw something on the X-ray, then did this patient have any pain or swelling in the region prior to the injury? These are the questions that should be asked to the patient or to the family. Whether this patient had any limp or antalgic gait before the injury, and whether this pain is disproportionate to the energy of the injury. If it was a low velocity injury or a small fall and still the patient is having severe pain, then there should be a concern about it. And whether this patient had any rest pain before this injury. If the answer to all these questions are no, then it is very likely you're dealing with an incidental finding on an X-ray. Most of these are due to some asymptomatic pathology. We'll come to that later. You then evaluate the X-ray and see whether there is any structural weakness in the bone and assess any future risk to the bone. Based on that, you may decide that this patient doesn't need any follow-up as far as the hole in the bone is concerned, or you may feel that some follow-up imaging is advisable, especially if you're not very sure what that thing is. It is a good idea to keep it under observation and monitor its behavior with serial X-rays, maybe a few months down the line. On the other hand, if this patient says yes for all your questions or any of those questions, whether the pain or swelling in the region prior to injury, whether there was limp, antalgic gait, or whether the pain is disproportionate to the energy of injury, or whether there is rest pain, or if the X-ray was done for any complaint of pain or swelling in the region, or any similar history in the past. If the answer to all these questions is yes, then you must see whether the finding on the X-ray corresponds to the clinical complaint of the patient, anatomically, clinically, and proportionally. Means whether the pain corresponds to the area of the lesion, whether it is actually arising from the bone or whether it is just from the soft tissues, and this X-ray find is again an incidental thing, and whether the pain is in proportion to what you are seeing on the X-ray. If the answer to these questions is no, then this could again be an incidental finding. You must consider other possibilities and investigate this patient accordingly. On the other hand, if the answer is yes, you may already have a potential diagnosis based on what you have evaluated clinically and what you see on the X-ray, or you may have a differential diagnosis, and based on that, you may decide on the need for additional investigations wherever indicated, and then plan the treatment or further management. So what are the points you look for in the X-ray? The most important thing you look for in the X-ray is which bone and which part of the bone is affected, whether this lesion is epiphyseal, metaphyseal, diaphyseal, whether it is medullary, cortical, or a surface lesion, and whether it is centric or eccentric. If you look at this picture, it elicits all those various different diagnoses that is possible depending on where this lesion is presenting in the bone. Whether it is epiphysis, metaphysis, diaphysis, whether it is centric, eccentric, whether it is cortical or medullary. The other thing that you need to look for in the X-ray is these 5 further points, that is pattern of bone destruction, whether it is geographic or permeative, What is the zone of transition, whether it is narrow or wide? What kind of periosteal reaction is there, whether it is there or not, and if it is there, whether it is solid or interrupted, whether there is any soft tissue extension of this tumor, and what kind of matrix this lesion has. Now, since we are talking about holes in the bone, we are only looking at radiolucent matrix. We won't discuss the other kind of matrix that we get to see. So basically, these are the points which help you in differentiating between an aggressive or a malignant pathology from a indolent or benign pathology. So let us see some of those common holes in the bone that you may get to see in your OPD. I'm sure most of the pediatric orthopedic surgeons have already seen something like this. This is the classic fibrous cortical defect. This is one of the most common benign bone lesions. In fact, according to literature, almost 30 to 40% of children may be actually having one of these, either this or the other lesion that we'll be discussing shortly. That is the non-ossifying fibroma. So this is a very common incidental finding in the lower limb X-ray of children. It is generally found in the metaphyseal or metadiaphyseal junction. It is a benign asymptomatic lesion. It is most often seen when an X-ray is done for some kind of injury. And this poses no real risk to the structural strength of the bone. It is a well-defined radiolucent defect in the cortex with benign features, which is generally very small, about less than 2 to 3 centimeters in diameter. It does not have a soft tissue mass. There is no periosteal reaction, and it heals with skeletal maturity. Nothing really needs to be done for this. Once you see a fibrous cortical defect, you can as well tell the patient to forget it. The next one is related to the same pathology, but this is slightly larger with the medullary extent of the disease. Here you see what is called as a non-ossifying fibroma. So this is a geographic lesion which is lytic, multilobulated. It is metaphyseal in location, and there is an intramedullary extension as compared to fibrous cortical defect, which is purely cortical. This is an eccentric lesion, means it is not in the center of the bone. It is to one side, and it generally abuts one of the cortex of the bone. It is well marginated. It has a sclerotic rim, and sometimes it can cause endosteal scalloping. So 30 to 40%, along with fibrous cortical defect, 30 to 40% of children over 2 years may have one or more of these lesions. Most of them are found in the lower extremities around the knee. Few of them may occur in the upper extremities. The vast majority of non-ossifying fibromas are single, and in 8% of cases, it could be multiple. Here we are seeing a non-ossifying fibroma in the fibula. Majority of these cases are again asymptomatic and are incidentally discovered, as we have seen with the fibrous cortical defect, when X-rays are done for some other reason. However, larger lesions may cause pain that is probably secondary to microfracture or an obvious pathological fracture. If you look at this X-ray, there is a small crack in the bone here, which was the reason why this X-ray was done. However, nothing needs to be done for this particular lesion. So what is the prognosis for this disease? Most of these lesions heal spontaneously by being replaced with normal bone. They migrate away from the epiphysis with the growth of the patient. They may undergo pathological fracture, as we have seen in that previous case with the fibula. They do not ever undergo malignant transformation, so there is no real fear with this particular condition. Most of them are asymptomatic and they don't need any treatment. The painful larger lesions where there is an impending or established pathological fractures are adequately treated with curettage and fixation. This is a young girl who came with a similar lesion in the proximal tibia with a history of pain, and on the MRI we could detect a pathological fracture, and for that reason she was operated. A curettage and ipsilateral fibula grafting was done, and which over a period of months healed completely. This is not a very good X-ray, but here is one of those other classic hole in the bones that we see. That is, I hope now you can probably make out faintly a small lytic lesion in the epiphysis of the proximal tibia. This is the classic presentation of chondroblastoma. These patients come with complaints of pain around the region, which may be a few months or sometimes a year in duration, because these are so small that they are not often easily detected. A symptomatic benign appearing lytic lesion in the epiphysis or the epiphysis of an immature skeleton is almost diagnostic of chondroblastoma. It is much better seen on this MRI. Here you can see this lesion here in the posterior tibial epiphysis. So these are radiolucent lesions that typically present in the epiphysis or epiphysis of long bone. They tend to be really small, less than 4 centimeters in size. They can be central or eccentric. They occupy less than 1/2 of the epiphysis. They are very sharply demarcated with or without a thin sclerotic border. And sometimes you may see matrix calcifications in about 1/3 of these cases. So these are benign cartilage producing neoplasms, usually arising in the epiphysis of skeletally immature patients. And they are quite rare, less than 1% of primary bone. Common locations are the epiphysis of the distal and proximal femur, proximal tibia, and proximal humerus. Majority of these patients will complain localized pain, which is often mild, sometimes of many months or years in duration. You may occasionally get soft tissue swelling, joint stiffness, and limitation of range of movement and limbs. In a minority of them, you may have joint effusion, especially when the lesion is around the knee. Prognosis is excellent. This is a very benign condition. Treatment wise, we have two major options. One is curettage with bone grafting, which was what was done most of the times for this. But nowadays, radiofrequency ablation is also a treatment of choice, especially for the smaller chondroblastomas. Like in this particular case of chondroblastoma proximal tibia, a radiofrequency ablation was done, CT guided, and 3 months later, the lesion is almost gone and the pain is completely gone. This is another 9-year-old boy with a large biopsy-proven chondroblastoma of the femoral head. You can see almost the lower half of the femoral head and neck is missing or sort of eaten away. These are the CT pictures where you can see how large this particular pathology is. So here, a surgery was planned, curettage and head preservation. So a partial subluxation of the head was done, curettage of the head with burying and electrocauterization of the tumor bed, and an iliac crest graft was wedged in. So this is the post-op picture, and over a period of time, the graft healed very well. At 4 months, it looks like it is consolidating. At about 1 year, this patient had a local recurrence of the disease, which you can appreciate here on the MRI, more like a cystic pathology. So he again underwent an extended curettage, plating, and allografting with fixation. And at 18 months, it has healed well. At 4 years post-surgery and 6 months post-implant removal, this head is looking good and the patient has got excellent function. Now we come to one of the commonest lesions, symptomatic benign bone lesions that we get to see is a simple bone cyst. This is a simple bone cyst in the proximal humerus. It is most commonly seen in the proximal humerus and the proximal femur. They are solitary lytic metaphyseal lesions which are adjacent to but not crossing the epiphyseal plate. With growth of the child, they migrate towards the diaphysis. They have well-defined margins with a narrow zone of transition. And if you notice, the long axis of the cyst is always parallel to the long axis of the bone. And sometimes whenever there is a pathological fracture through the cyst, you may get to see a fallen fragment sign, which is often considered pathognomic for a simple bone cyst. MRI is always advisable whenever you are evaluating any bone tumor. Now, the thing that we look for in an MRI is whether it is demonstrating a unilocular cyst. So here we can see this is a single cyst, fluid-filled cyst. Sometimes with repeated fractures, the MRI appearance or even the X-ray appearance may get altered, but in that case, you will have a history of repeated injuries with this particular patient. Whenever there is a fresh fracture, you may see, due to the collection of blood in the cyst, a single fluid level in the MRI. 85% of these patients are detected in the first decade of life. Males are more commonly affected than females. The most common locations are proximal humerus and proximal femur. If there is no fracture, most of them are asymptomatic. They are often discovered suddenly due to a minor injury, which leads to either a small crack in the bone or a complete fracture. And that is how they come to the notice. So the indication for treatment is to reduce the potential risk of pathological fracture and to alleviate pain. So around 20 to 25% of these cysts may heal following a pathological fracture. For the rest, you may have to do some treatment. There are different ways of treating a simple bone cyst, and therefore there is no consensus on what is the best way to deal with simple bone cyst. Steroid injection or injection of autologous bone marrow or demineralized bone matrix are minimally invasive ways of treating simple bone cysts. However, these procedures may have to be repeated at say 6 to 8 weekly intervals. Maybe you may have to do it 2 or 3 times. The tried and tested method is curettage and bone grafting. However, it is quite an invasive procedure and generally reserved for those cases which have not responded well to these minimally invasive ways of treating the simple bone cyst. In situations where the cyst is in the femur, one may need to do some sort of fixation using a plate or an intermedullary device, especially to prevent any sort of fracture, deformity occurring in the weight-bearing bone. Very important is that at the time of primary management, you should send some of the scrapings from the wall of the cyst for histopathology for documentation. Sometimes an aneurysmal bone cyst can also sort of mimic the presentation of a simple bone cyst. So this is a simple bone cyst of the proximal humerus which has healed with conservative management. This is a 11-year-old child with pain in shoulder. X-ray revealed a large diaphyseal simple bone cyst which was treated with one single shot of steroid, and at 5 months the cyst seems to have healed completely. This is a cyst in the subtrochanteric region of the proximal femur, which was fixed with tense nail. This is a 9-year-old child who presented with pain and a crack in the subtrochanteric region. This was on MRI. You can see a single fluid level here, which is what we would expect to see in a simple bone cyst. Curettage, allograft, and a fixation was done. And over a 1-year period.
In some time.
Mandar, yeah.
Yes.
Hello.
Yeah, can you wind up sometime? We are already slightly over time.
Okay. All right. So I'll just cover this aneurysmal bone cyst and get out. So aneurysmal bone cyst, you see this ballooned out appearance. It is an eccentric location, most commonly arising in the metaphyseal long bone. You see this with well-defined margins, marked cortical thinning and erosion. Radiological differential diagnosis, simple bone cyst, GCT. Majority of them are in the first 2 decades of life. There is no sex predilection. And site of involvement, you may see it in the proximal humerus, proximal femur, and tibia. MRI is very important modality of investigating ABC because you have to rule out any solid component, which is to rule out a secondary ABC. Telangiectatic osteosarcoma is an important differential. Presence of fluid level is not diagnostic of ABC, so there is no foolproof way of differentiating it from a telangiectatic osteosarcoma. So biopsy confirmation is therefore very important. ABCs you can treat with percutaneous sclerosant injection or with curettage and grafting or something what is called as curopsy. This is the ABC of the lower end radius, which was treated with sclerosant injection, which has healed completely. This is the ABC of proximal humerus treated with sclerosant, which didn't respond and had to be treated with curettage and bone grafting and fixation. And this patient has had a good outcome. I think that will be it. Mandar?
Yes. Thank you very much, Dr.
Chetan. Yeah. Sorry for extending your time.
So I think if you can go back to the last slide of the protocol, I think this slide is an extremely important slide. Yes. And that has to be, probably we can take a screenshot of it, and that has to be pasted in our mind more than anywhere else.
Correct.
Manage a hole in the bone in a child.
Yeah. Just a simple way of,
Absolutely.
Yeah.
Thank you very much, Dr. Chetan. We'll go to the next session. If you can unshare your screen.
Yeah. Let me just do that. How do I? Yeah.
So we now go to the next speaker. We have Dr. Rujuta Mehta, who is the honorary consultant and head of Department of Pediatric Orthopaedics at the Vijay Hospital for Children. She's also a consultant at the Nanavati Super Speciality Hospital, the Jaslok Hospital, and the Shushruta Hospital. And she's going to talk to us on a very important topic, which is a common foot problems in the neonatal period. Are they all clubfoot, and what are the other deformities in the spectrum? Over to you, Dr. Rujuta Mehta.
Yes, so good morning, everyone. And is the screen visible now?
Madam, it's not. Yeah, now it is. Yeah.
Okay. So we are basically, I think in pediatric orthopedics, we all are a little feet happy surgeons, and our job really is to make it happy feet. And what I'm going to try and do today is really talk to you more about every foot problem that really comes to a pediatric orthopedic surgeon, beginning from the neonatal to the adolescent very, very quickly. The top down 5 countdown always is clubfoot, which may be either postural idiopathic or a syndromic club feet, and there are many varieties. But if you really look at the whole list which I'm sharing here, we do get a whole lot of other referrals like metatarsus adductors, pes calcaneovalgus, vertical talus, and oblique talus, which all look very similar in addition to the other conditions that I've listed out to here. And we need to know very clearly how to differentiate them, all in the pre-walking age group. As well as in the walking age group, there are a lot of common OPD referrals. So I think it will help the orthopedic surgeons to know a little bit about all of these things as well. Again, right from the simple flat foot, which is called pes planus, to an oblique talus, in-toeing, out-toeing, which is again a very common problem. And sometimes you need to know how to differentiate the tarsal coalitions and accessory naviculars. Some other common conditions like osteochondritis and cysts, infections, always never forget, will always be part of the gamut, and the traumas and sprains, and in addition to some tumors, which I think very few sites in Dr. Chetan's lecture, I'm sure you'll be able to pick that up. So let's quickly go about looking at the common ones. When a child comes with deformed feet, which are twisted in all directions, I think the whole family goes into panic. If the foot is plantarflexed, dorsiflexed, there are 2 common diagnoses here. If you're able to dorsiflex and evert it, most likely you're dealing with a postural clubfoot, which is completely correctable in the first 6. But if you're not able to dorsiflex, then you're dealing with a typical clubfoot, and you will probably need to go on to the Ponseti technique. Whereas if the fulcrum of the deformity is really at the ankle and not in the foot, like shown in this picture again, whether it's there, then it is a pes calcaneovalgus, or whether it's in the lower tibia, then you're dealing with the congenital posterior medial bowing of the tibia, which looks very similar, but however, the deformity is not in the foot at all. And both these conditions are benign and essentially do remodel with over time. You just need to be patient, do some exercises, and use some splintage and wait and watch. But however, the fulcrum of the deformity is in the midfoot, then 99%, the other common condition as severe as the clubfoot, which you need to look at, is the rocker bottom foot or the congenital vertical talus. And this needs a plastering technique, again, like the clubfoot, but in the reverse direction, or known as the reverse Ponseti. So we'll quickly look at both of them bit by bit. Do remember that you need to differentiate the clubfoot from the metatarsus adductus, which essentially has no deformities in the hind foot, and you only have a forefoot which is bent inwards, as you can see over here, whereas a clubfoot will have deformities in all components, whether you see it from the front or the back, and this needs a lot of plastering. How will you differentiate these 3? If you have a less severe and a flexible foot, which is correctable in your hands with no equinus deformity, which is usually due to uterine malposition, then you're dealing with a postural CTV. The treatment for that will be observe, stretch, do some peroneal stimulations, give a heat molded brace in the first 6 weeks, maybe 1 or 2 times you may need to repeat it, and the problem is usually solved in subsequent OPD visits. Whereas a metatarsus adductus will have largely the forefoot just adducted, the lateral border of the foot is curved, but there is absolutely no deformity in the heel, no equinus or no varus at all. So the treatment here is going to be observe. If rigid, sometimes, only sometimes it needs casting, but nowadays most of us have switched on to the Steenbeek brace at night and nap time, and in the daytime AFOs, and usually by the age of 5 these resolve quite well. Or a simple technique is to use reverse port shoes. So coming to the quintessential classic clubfoot, you will look at it in the anterior view and the posterior view. You will notice that in the anterior view, you see adduction and supination of the forefoot and equinus of the hindfoot. Whereas in the posterior view, that is in the foot end, you will see the inversion, plantar flexion, internal rotation of the calcaneus and the cavus with the transverse plantar crease. All these deformities rolled into one. So since it's a multi-apical problem, we may be a little foxed as to how do we assess. The commonest technique now followed all over the world is Pirani scoring, which we'll see in a bit. And the commonest treatment, which now all of us follow, and it has become the gold standard, is a Ponseti method, which is a serial 1 weekly casting. It's essentially a conservative OPD treatment, which stretches out the deformity gradually in stages and works best in the neonatal period. The tenotomy at the end of the 5 or 6 plasters that you will probably need is done under either local anesthesia or can just be done in your clinic, and it's a minor procedure. So once you explain all this to the parents, they're usually very happy that the neonate who has been brought to you with a lot of fear and stress, you tell them in India that Namkaran ke pehle, we will make your, and they're usually very, very at the end of 1.5 months, the child is going to have a straight foot. So what are you going to do in the Ponseti technique? You're going to address one component at a time. You're going to do a gradual, skillful plastering, which will take first the cavus and the adduction in the forefoot that lead to pronation. Then will correct the medial displacement of the tarsal bones and realign them with the midfoot. And last, with your few plasters, you will solve the heel varus and inversion in the high foot. Do we do that? Let's look at it in 3 planes. In the modulus, the frontal plane, that's the cavus which you start eliminating. Align the first ray with the rest of the foot. Bring it gradually to abduction. Notice the finger at the head of the talus in the bone model, and you see how it comes out fully into abduction beyond 70 degrees, and the talar head is gradually going into the ankle mortise. And at the same time, corresponding to this, what is happening here at the heel, because of the kinematic coupling, what you're doing at the forefoot is gradually taking the axis of the calcaneum from a varus into neutral and then into a valgus. And this is how your plasters would look at the end of the first 3 plasters when you go on abducting. And this should be the final outcome after the tenotomy. So it's a very simple technique, takes a bit of learning, but once your hands are skilled and you're ready and set with it, it gives absolutely rewarding results. So how will you assess them? I spoke a little bit about the Pirani score. We'll just take a very quick look at it because I think every orthopedic surgeon should know this. So it essentially concerns 2 components, a midfoot score and a hindfoot score. We won't go too much into details of this because this is not a lecture on clubfoot. But you must remember that all these signs you can actually pictographically assess very quickly in 2 minutes. And if you put up the charts, which I show you some of the pictures in the next few slides, it's very easy for you to even monitor how well your treatment is going and sometimes pick up errors in between. So the midfoot score and the hindfoot score, each of 3 and a total score of 6, that would indicate a big severity. So you look for 2 points, that is a medial crease and the posterior crease in the child. You feel for 2 points, which is the lateral head of the talus and the empty heel, and you measure for 2 points, which is the rigid equinus and the curved lateral border. How do you do that? Midfoot contracture, that's your curved lateral border going from normal to severe, so that is 0 to 1. That's your medial crease again going from normal to severe, 0 to 1. That's your lateral talar head coverage. This you have to do as you are correcting it. So this is your finger on the head of the talus, 1 centimeter in front of and below the fibula. And again, going from 0 to 1, that indicating the severity. The posterior crease, severity 0 to 1. And the equinus, whether able to get into dorsiflexion or no, from normal 0 to 1, indicating a very rigid equinus. And finally, your empty heel, which if it feels like as soft as the lip, then it's usually in the 1. And if it feels like the tip of your nose, that you're able to feel the bone over there, it's almost normal, that is 0 and 1. So as your Pirani score goes down, your clubfoot treatment plaster should improve. And when you reach a straight lateral border like this and your midfoot score comes down to 0, that is when you proceed with the tenotomy and go ahead and achieve full dorsiflexion. And those are the kind of results that you can get. See a tight, rigid clubfoot after serial plastering, straight lateral border achieved. And that's the amount of 70 degrees abduction, full correction, and followed by tenotomy. Similarly, a bilateral clubfoot after 3 plasters went ahead with tenotomy and then full correction at the end of it. And that's the kind of function you can get if you follow them up for 4 years. These children go on to run, jump, everything. Yeah, the most important thing after doing the procedure is going to be maintenance of the brace. So a few take-home messages for the Ponseti technique. What will you always do? You will correct the cavus. You will cast every 5 or 7 days. From the second cast onwards, or abduction in a supinated foot. Do not pronate or do not try to achieve dorsiflexion at the same time. You do your tenotomy only after you've achieved 70 degrees of abduction. The earlier you start, the better are the results because of the effect of relaxant. So as early as 4 to 7 days of life, you can start this method. The don'ts are never pronate, never correct the equinus before heel varus, never neglect your bracing protocol because it's after this only that the maintenance phase starts, and that is as important as straightening the foot. Never try to raise the stages and never start before proper counseling, because if you really have explained all this to the parents, you can get extremely good results. However, it's not a utopia. The commonest problem after clubfoot correction by the age of 4 or 5 is overactive tibialis anterior, which causes again a dynamic supination deformity as shown over here. The pictures speak for themselves, where you can see that the child is walking on the lateral border of the foot, and that's the foot turning in every time the child walks. So what happens here is a good correction of the foot and the varus. There's a equinus which has been corrected. On dorsiflexion, the forefoot supinates and adducts. This is largely due to a muscle imbalance between the inverters and the everters and a very, very strong or overactive tibialis anterior and weak peroneal muscles. And this can be corrected by simple tib-band transfer. We will not go into the details here, but that's the kind of follow-up that you can get with full range and a full correction. The beauty of this procedure is that it eliminates the need of any footwear later. And in our country, always clubfoot referrals can be late also. So sometimes you have to do surgeries. If the clubfoot presents late, it's necessary for rigid deformities, but conditions apply in terms of you should know which surgery to perform when. If you're electing an open surgery, you have to release a few ligaments and move the bones. And in very late presenting club feet, you may need to use fixators, which is very similar to Ponseti at a later age. Sometimes if the patient comes from far off, you should also need to know some osteotomies in order to get better tissue alignment over there and shorten the deformity at one go. But however, we will not talk about all of these again. And in very, very late presenting adults, very occasionally do you need to arthrodes now, which was as was told in the olden days, but now hardly we really find it in practice. So very quick look at some surgical modalities.
Madam,
there are a lot of transfers.
Slightly over.
I'm sorry?
Can we wind up, madam? They're slightly over.
Yeah, this is just coming to an end now.
Yes. Sorry.
So these are now the releases, as I can show you the deformities, the positioning, the tendoachilles and the 3 tendons which needs to release, and you get a completely full correction out there. And if there are skin problems, then you can even shift a flap down as shown here. And fixators, again, a technique we won't talk about, but very good results if clubbed with soft tissue releases. And finally, the last thing that you need to know, the CVT or the rocker bottom boat-shaped foot. As you can see, the deformity is completely in the midfoot here, and the calcaneum is always in equinus. The arch is collapsed, and you have a fixed dorsal dislocation of the talonavicular joint. So how is this treated? You will identify it on the lateral x-rays in both plantar flexion and dorsiflexion. The calcaneum persists in equinus. If you put it in plantar flexion, you will see that this usually aligns better, and the talonavicular joint dislocation is corrected. It is generally an oblique talus is less severe than that, and the calcaneum is not in equinus, and that's how you differentiate it from an oblique talus. But in a true CVT, the calcaneum will always be in equinus. So you again start, like we spoke in the Ponseti in the club foot, now do serial plasters by the reverse Ponseti technique. Again, same weekly rhythm, again OPD procedure. And at the end of it, instead of the tenotomy, you do a minor operation under the C-arm. You could do it at any age, say about from day 5 or day 10 up to a few months of life, as which, failing which you can do operative treatment and not resort to the reverse Ponseti. But those are the kind of results you can get with reverse Ponseti. As you can see, everything is corrected except the mild degree of heel varus, for which you may need a tenotomy, and the tibio-navicular joint, which will need an open reduction like shown in the picture. That's the kind of correction you can get even at a later age with the full release. So thus, having shown you the last thing, the calcaneovalgus, which is the commonest benign condition. Again, it's usually postural due to interuterine crowding, and you have to just resort to serial manipulation by the mother in club feet. Very rarely in a syndromic calcaneovalgus do you need to do operative release anteriorly like shown here. And the posteromedial bowing, which we spoke about, here the deformity is totally in the tibia. If it does not autocorrect over a period of time, which is it's supposed to by the age of 7 years, then we have to resort to lengthening. But largely, the degree of bowing which you see at birth tends to remodel over a period of time, and just keep monitoring the limb length discrepancy, and only bracing is required at birth. So these are the 4 common neonatal conditions that you see, and you should know how to differentiate each one and treat each one. And trust me, if you're a foot happy surgeon, you can make all your patients go back home with happy feet. We'll stop there. We can take any questions.
Thank you very much, madam. That was really an extensive overview of all the pediatric neonatal birth foot deformities. We'll go to quickly to the next section, which is the first lecture will be taken by me on the pediatric orthopedic X-rays. All right. So is my screen visible? I think so. Yeah. So basically, my brief for today is on pediatric orthopedic X-rays, how not to misread them to not mislead the diagnosis. And as we know, pediatric orthopedic X-rays are extremely confusing. There are trauma X-rays, tumors, infections, hip, metabolic, and all these lead to a lot of confusion. So what I'm going to do is I'm going to explain how to diagnose pediatric orthopedic conditions based on a mnemonic, which is pediatric, P-A-E-D-I-A-T-R-I-C. Now, let's see each one of them. So we have the first case. It's a 6-year-old girl with severe bilateral genu valgum, probable skeletal dysplasia, and I planned for a deformity correction. And I asked for a scanogram or a teleradiogram, as Dr. Sandeep said, and this is what was obtained. Here I could see that the deformity is completely not there. It's almost like a straight limb. How did this happen? Well, the radiologist or the radiology technician, usually what it does, the ideal position is a patella facing forward. Instead of that, they externally rotate the limb so as to have both the sides on the same plate, and that is where the deformity gets completely masked. What do we look for in a scanogram? We look for the mechanical axis or alignment of the knee and the tibia. We look at a few angles like the MPTA and the LDFA. We look for limb length discrepancy, and that, you remember, it has to be done with a block under the shorter side. Only then do we know that there is exact limb length discrepancy. The first is very important, which is the positioning of the child for the X-ray. Patella facing forward and a block under the short limb. A is an 18-year-old female, came with severe signs of septicity. And you could see that the WBC count was very high, ESR was very high, CRP was very high. I suspected a septic hip or an osteomyelitis of the femur. I called the radiologist up. I told them that this is what I'm sending for. The radiologist called up. She said, sir, nothing in the hip or the femur, but you are suspecting some infection. Do you want us to screen the tibia also? I said, please do. And what I found was there was a severe osteomyelitis of the tibia, which I drained, and she had a very good result. As against that, this was another child who I suspected some infection. He was sent by an ultrasound by the pediatrician. The USG of the hip showed all the various angles for DDH. but nothing about the synovium of the hip, nothing about the effusion. And finally, when the X-ray, which was reported by normal, and an MRI was done, you could see that there was a huge amount of effusion and a subluxation of the hip. So all you have to do is A, which is ask or communicate with the radiologist before sending for any investigation. E, you have a neonate with pseudoparalysis of the left upper limb after a birth trauma. You have this X-ray. It was reported as an elbow dislocation, but what you should know that this is not an elbow dislocation, but something known as a transphyseal injury of the distal humerus, as a relatively common injury. What you should know is about the presence of the radiocapitular line. Look at it on the AP view and look at it on the lateral view. In this case, where a 4-year-old male was diagnosed to have nothing on the X-ray by the radiologist, but as you can see that the radiocapitular line was missed on the lateral view, and this was a missed montagia, which required a flexion osteotomy of the ulna. You should remember about all the ossific centers of the elbow, and thus the elbow, the enigma should be de-enigmized. So you have the enigmatic elbow as E. What's D? You have a child, a 6-year-old boy, fallen outstretched hand, comes with severe pain in the elbow, and slab was given elsewhere, where the X-ray was reported as normal. Are we satisfied with this X-ray? No. You could see that you could get a good internal rotation oblique X-ray without a slab, and you can see that it was a grossly displaced lateral condyle humerus fracture, which required surgery, and thus always get good quality X-rays with different views, like the oblique views, especially with the elbows. D is different views. You come to I, you have a 9-year-old boy who had symptoms since 3 months, showed multiple doctors, and has increasingly severe pain in the last few months, and was asymptomatic after an alleged history of trauma. He had severe pain and tenderness over the upper posterior tibia, was barely able to walk. And I went back to the history. Did you show anyone for the trauma? He said he did not tell anyone. It was just that after asking that he said that he had trauma 2 weeks back. And this was the first X-ray, which was reported as a suspected physeal injury. But on X-ray at presentation to me, this was a totally different picture, which was proved to be smear positive Cox. So we should always remember to ask whenever there is a history of trauma, why do you think the trauma is related to the present symptoms? And many a time this X-ray, this has been reported as an infected organized hematoma. It's almost mythical unless in specific conditions like Morel-Lava lesions or bleeding diathesis. So don't think of trauma unless there is an actual specific one. So beware of incidental trauma, which is I. What is A? You have an infant female breech, firstborn, has come with a left hip click. The X-ray was done by a pediatrician, which was reported as normal. Many X-rays done over time, but now you can see that the child is now about 1.5 years old with a frank dislocation of the hip. Always try to draw the lines in a neonatal hip X-ray. We know the Perkins and the Hilgenreiner's line. Try to classify the hip as per DDH classifications so that you should not miss a DDH. Thus, A is draw various angles and lines, especially in pediatric hip X-rays. This is another case, a 15-year-old boy who's athletic, has pain over the both upper tibia, and again an incidental trauma history, and diagnosed to have avulsion of the tibial tuberosity. What is this? This is Osgood-Schlatter's disease. Second is a 13-year-old female comes with the pain over the lateral side of the foot for 4 weeks, has a history of twisting injury, has point tenderness over the base of the fifth metatarsal. What is the diagnosis? This is an Iselin's disease. So this is basically osteochondritis, chondrosis, or traction apophysitis. Various names at various locations, Osgood-Schlatter's, Iselin's, Kohler's, etc. These are extremely benign conditions in adolescence. They almost never require any major treatment. They are treated symptomatically. So you should remember about the presence of this traction apophysitis. Don't diagnose them to have fractures. The next is a 14-year-old male comes with thigh and knee pain since 4 months, has difficulty in sitting cross-legged, has numerous investigations been done with respect to the knee, including an X-ray and an MRI. But what he had was something upstairs, which is a slipped capital femoral epiphysis. Remember, it's one of the most common causes of early hip arthritis in a child and medical litigation for misdiagnosis. So any adolescent with thigh and knee pain, get the right hip, right joint X-ray, get a pelvis X-ray done. So get a right joint X-ray. So R is right joint X-rays. You have a newborn whose breech, and it was referred to me for a widely abducted position of the pelvis. And it was referred for a huge mass in the pelvic region. This was the actual reporting which was done. A large soft tissue mass seen in the sacral region. Please correlate with clinical and investigation findings. Suggested an MRI. The relatives and the neonatologists were extremely perturbed. I did one emergency procedure in this and the mass was gone. What did I do? I just removed the diaper. So basically, think of extracorporeal issues due to innerwear in a small child. See to it that you get especially a pelvic X-ray done without the diaper. So I is innerwear or diaper. And last, you have a child with a long-standing bow leg deformity and trivial fall and inability to bear weight, diagnosed to have tibial plasters and fracture and plastered. And on examination, you can see these cafe au lait spots. And the diagnosis is congenital pseudoarthrosis of the tibia with NF1 or neurofibromatosis 1, one of the most difficult conditions to treat for a pediatric orthopedic surgeon. Another child, mother noticed swelling over the right shoulder since 15 days. Here she is specific that there was no history of trauma. Someone diagnosed to have fractured clavicle, given brace elsewhere, comes back to me with an exactly same looking X-ray with no callus at all. So what are we dealing with here? The question is, why am I showing you a simple case of fractured clavicle and why did I highlight right? Well, this is a congenital pseudoarthrosis of the clavicle, one Hutke case which can be seen. It does not require any treatment, almost always occurs on the right. And if it occurs on the left, think of dextrocardia. So know of some Hutke conditions. So last is conditions which are Hutke or unique. Thus, finally, to reiterate, positioning, ask or communicate with the radiologist, think of enigmatic elbows, different views, especially around the elbow, beware of incidental trauma, draw angles and lines for pediatric hip X-rays, beware of traction epiphysis site is being diagnosed to have fractures, do the X-rays of the correct joints, remove the diaper when you are doing a pediatric pelvic X-ray, and know some of few conditions which are unique or Hutke. Thank you very much. So we now go to the next talk, which will be given by Dr. Binoti Sheth. Dr. Binoti Sheth is an associate professor and the head of the unit at the Sion Hospital and a consultant pediatric orthopedic surgeon. She is going to talk to us about an important topic, which is on pediatric bone and joint infections, how to manage them, how not to miss them, and the protocol for management. Over to you, ma'am.
Good morning, everyone. Let me start with a common case scenario. A 2-year-old female child with history of trivial trauma presented to an orthopedic surgeon with pain and swelling in the right forearm with fever. The surgeon took the X-ray, found that there was no bony injury, and sent the child on oral analgesics. After 1 week, when the child continued to have increased swelling and pain, went to a surgeon now who treated her as an abscess. An incision and drainage was done and antibiotics were given for 6 weeks. The child presented to me 1 year later, and look at the X-ray, what has happened. There's near complete loss of radius. And this happened because the child actually had an acute osteomyelitis of radius, which was missed by the orthopedic surgeon because there was underlying history of trauma. So remember that history of trauma is present in up to 30% cases, and it should not mislead the diagnosis. So why is that the diagnosis is missed or delayed? Because there is no single clinical finding or test that consistently allows rapid diagnosis. Especially in neonates and infants, the presentation is sometimes very subtle or mild because their immune system is immature. And there are many conditions like trauma, neoplasm, inflammatory arthropathy, transient synovitis, scurvy. They all have clinical picture, which is very similar to infection. And even if you're suspecting infection and you have all the other diagnoses favoring infections, in almost 20%, no organism is identified. So if you have to want to diagnose it correctly and in time, you should have a very high index of suspicion and then correlate the clinical presentation with lab parameters, radiological investigations, and microbiological tests. So what is classical clinical presentation? Well, you can have pain, tenderness, swelling, erythema, fever, restricted range of motion of the adjacent joint, presenting like a pseudo-paralysis, inability to bear weight, and limping child. But look at the percentage of patients who have these signs or symptoms positive. Something as significant as fever is present in only 60%. So you do need some additional investigation to support your diagnosis. So simple thing to do is to do blood investigation. When you have an underlying osteoarticular infection, there could be elevation of WBC count, ESR, and CRP. And remember, CRP is a very sensitive and reliable investigation because it is raised within 6 hours of the infection. It reaches peak by 2 to 3 days, and it normalizes within 1 week of successful treatment. And if your CRP is very high, say more than 100, then you should suspect that there could be concomitant osteomyelitis and septic arthritis, or you presume a complicated course. Sometimes there is a newer investigation which is very highly specific and sensitive for bacterial infection, and that is procalcitonin. But unfortunately, it requires special quantitative immunodiagnostic test and hence not routinely done. Another confusing picture in small children is how to differentiate septic arthritis from transient synovitis. And in a landmark paper, Mininder Kocher has described this very wonderful Kocher's criteria, which takes into account 4 factors. If ESR is more than 40, WBC count more than 12,000, the child is unable to bear weight, and if fever is more than 38.5 degrees centigrade, if all 4 factors are present, then almost 99% chance that you are dealing with a case of septic arthritis and not just transient synovitis. And one more feature of CRP more than 20 was added by Cade in 2006. And he also said that if there are all 5 factors are present, then the chance of having septic arthritis is almost more than 97%. So these are very important criteria which can correlate clinical and blood parameters. What about radiological investigations, which we orthopedic surgeons are very fond of? Does it help in diagnosis of osteoarticular infection? Well, initial findings such as soft tissue swelling or joint space widening in septic arthritis, because bone changes take almost more than 5 to 7 days to show the typical changes of periosteal reaction and other things. But still, it is important to do plain X-ray at the outset because it helps us to sometimes rule out the other pathologies which may mimic infection. Ultrasonography is a very good sensitive investigation which can diagnose the underlying joint effusion and subperiosteal collection. And it can be done easily bedside and non-invasive, but it is again operator dependent. So very important radiological investigation in case of infection is MRI, and it is a must to do in all the cases because it can help us to differentiate between cellulitis and osteomyelitis, between osteomyelitis and tumor. It also helps us to identify abscesses which are especially present at unusual sites like in pelvis. It can help us differentiate and plan surgery, but the disadvantage is the cost, the sedation required, and the time required. Finally, microbiological diagnosis is a must prior to starting any antibiotics, but it should not delay the treatment in unwell child. You can do the test from synovial fluid or the bone aspirate. Also remember to send a core biopsy because sometimes tumors can mimic infection and hence histopathology is important. And also send blood culture always prior to antibiotic treatment. And depending upon the age of the child and special situation, this table depicts which cultures you should send and how. Like for example, if it's a child is immunocompromised, you have to send the whole gamut of aerobic, anaerobic, fungal, and acid-fast bacilli, and again repeat them as and when required. So diagnosis done is half job done. Now comes the treatment. So what is the aim of treatment? It is to control and eradicate infection, prevent the spread of infection and prevent progression to chronicity, and ultimately prevent such major complications like growth arrest, post-septic hep sequelae, and chronic osteomyelitis. So what are the methods of treatment? Do we do medical treatment with antibiotics or do all of them require surgery? Well, always we have to start when you're suspecting any infection, empirically the antibiotics for that particular age and what is the most probable organism significantly prevalent in that particular age group. And you can refer to this table for the specific dose and the choice of antibiotics. If required, you can consult the infectious disease specialist. How should we give the antibiotics, IV or oral? Well, initially it should always be intravenous for about 3 to 5 days. But the current trend is early transition from IV to oral. So monitor if the patient is improving clinically in terms of pain and fever, and especially if CRP is falling, it falls to less than 50% of original or comes between 20 and 30, you can switch to oral. The prior duration concept was treat for 6 weeks, but the current recommendation is you can very well treat them for 3 to 4 weeks with successful result. But if there is MRSA or complicated cases, you may require longer duration. What about surgery? Which patients of osteomyelitis require surgery? If there is failed initial antibiotic treatment, if there is presence of large abscess on MRI, or concomitant septic arthritis, then you may require to drain them by making a cortical window in metaphysis or making multiple drill holes in diaphysis. What about septic arthritis? Do they require surgical decompression? Well, it is a must because it can prevent cartilage damage by the inflammatory cells. It can reduce the stretch on the capsule and thereby prevent any instability. And especially in hip, it is important to minimize the risk of AVN due to vascular tamponade. So you may think, can we just do an aspiration and then supplement with antibiotics? Well, occasionally for very superficial joints and early presentations, you can. But the disadvantage is that you may require repeated aspirations, and sometimes thick pus is difficult to aspirate. So the sure and the most definitive way of decompressing the joint is to do an open arthrotomy, and thereby removing the purulent material as well as the necrotic soft tissue and bone. You can very well do the lavage. It allows you to visualize the articular cartilage. And remember that leave the capsule open, put a drain so as to drain all the infective material. And lastly, don't forget to immobilize after doing any drainage or decompression procedure. You can do just with Paulick harness in small children or plaster cast or as and when required. This helps not only to reduce the pain, but also to prevent pathological fracture. So if I have to summarize, pediatric osteoarticular infection continues to present diagnostic as well as therapeutic challenge because there is no gold standard test. What you require is a very high index of suspicion and supplemented with judicial use of laboratory, radiological, and microbiological parameters. Medical treatment with antibiotics is recommended in early presentation of acute osteomyelitis. You have to add it with surgical drainage if it fails, and surgical decompression is mandatory for septic arthritis. Thank you.
Thank you, madam, for that excellent overview and finishing right on time. We will now be going to the next speaker. We have Dr. Chasanal Rathod, who is a consultant pediatric orthopedic surgeon at the SRCC Children's Hospital, the Children's Hospital Malar, and the Jupiter Hospital. She has a special interest in cerebral palsy and upper limb surgery. Today, her topic will be something which is very common, and it is almost like a pain for us, which is growing pains, along with another common topic, which is pulled elbow. Over to you, Dr. Chasanal.
Yeah. So thank you, Mandar. And just a second, I'm going to just share my screen. So thank you everyone for joining us on this Sunday afternoon. And I'll be talking about two common conditions seen in office, known as the office orthopedic conditions. One is the pulled elbow, and second is the growing pains. So pulled elbow is like usually we see a kid who's kind of howling and not being able to bend the elbow, and there's no particular history of any injury or fall, or maybe half of the times the parents are not aware what exactly has happened, but they're very much sure that the child is not bending the elbow. And probably that could be one of the suspicious point or the thing which we can consider to diagnose the pulled elbow. And pulled elbow is known by different names, and they are like, it's a quite common thing which we see across. So it's basically a soft tissue injury of the proximal radial ulnar joint, and it's caused by sudden pulling or traction of the arm. Its incidence is very low, that is 3% below the 5 years, although it's slightly more in older children, and it's more common in males as compared to females, and the left or the non-dominant extremity is more common. So common causes would be usually when the child is holding the parent's hand and taking a walk, and there's a sudden pull or a sudden jerk. That could be one of the reasons. Second is maybe during a playful, like the swinging or jumping or crossing the road or jumping over an obstacle. with the parent lifting on the forearm could another one of the cause for this. And second is, again, if the child is about to fall and in an attempt to stop the fall, the child being held by the arm. Another reason is a small baby being held up by the older sibling or trying to being pulled up by holding onto the arms can also cause this pulled elbow. So basically, it's the radial head which is subluxating from the proximal radioulnar joint. The child could have an inherent generalized ligamentous laxity or an annular ligament laxity, or there could be a disproportionate between the radial head and the annular ligament. This condition has been classified based on USG, and so usually an X-ray is not required, but if at all any test, if needed, it could be an ultrasound, and it can help us differentiate to understand what is the position of the annular ligament. Is it interposed, or is there been a split or something in that? And the clinical features, like I said, the child keeps the elbow, the forearm is pronated. The child would not want to move the elbow at all. And on touching the elbow, the child is crying, and it like just hangs like it's been limp. So like I said, we don't need any investigation. Only if the history is doubtful, if there has been a history of a trauma. And usually even if we do an X-ray in this condition, it's going to be like a normal X-ray, and only a slight proximal increase could be seen in the proximal radial length, but also it's like just kind of a doubtful finding, and it could vary from age to age on the X-ray we take. So at times the X-ray can be a therapeutic X-ray, or if we are able to convince the parent that we don't need an X-ray, it's probably not required. Ultrasound is a much more better option, like even mentioned in the literature, because it's also helpful in especially in the recurrent pulled elbows to understand what is the status of the annular ligament in these recurrent procedures. So the treatment is, it does not require any fancy treatment. It's just a basic office procedure, and just in the clinic while. So probably in the first talk, which Dr. Swapnil said, that how to examine a child in the clinic. So the important thing is the child remains on their mother's lap or the parent's lap, or either they are holding it on their shoulder, and it's nothing major procedure is needed apart from this. So the child has to be just consoled with the parent, and so the technique would be to just hold the hand like a handshake position and just support the elbow with the other arm and just supinate. And while supination, a click is felt, and post this, the child should be just left alone to do an active movement, which can be actually seen immediately in 5 or 10 minutes. So there's an immediate relief of pain. The child starts moving the elbow, and that's how quick the procedure is. At times, even while just evaluating, the pulled elbow is reduced. So there's no question of all the investigations or the things which I have mentioned. Another maneuver which is also described, and it is very common amongst the pediatricians. I mean, I have seen many of the pediatricians doing a hyperpronation maneuver, and I think it doesn't work very well as compared to the supination maneuver, which I just mentioned. Okay, and the child doesn't need an immobilization post this. Like I mentioned, that immediately the child will be having a relief. The child will start moving the arm, or if we offer a chocolate or any kind of a candy, the child will be happy to accept it, unlike the child was hostile or crying before when the radial head was subluxated. And only a slab might be required in cases of recurrence. If there are repeated pulled elbow episodes and the child is visiting repeatedly in few months time gap, then probably a slab should be advised. Otherwise, nothing is required. So, and recurrence is actually quite high. We often see these kids coming regularly to the clinic, particularly those who have an elder sibling and those who are very playful. And during this pandemic lockdown, actually, there were a lot of pulled elbows as compared to the regular practice time, which I have come across. And I think the recurrence, if they are like till 5 years of age, they should just be like monitored. And at times the parents learn the reduction maneuver, so maybe even they are good at reducing it by themselves. But yeah, a word of caution of how to handle the child and to hold the child from the trunk, or maybe by grabbing the child below the axilla is much more better and proper counseling of the parents helps us to get over this recurrence basically. So to conclude, I would say it's a subluxation, just to summarize, it's a subluxation of the radial head through the annular ligament. It's quite common below 5 years old, and it should be suspected if the child is not moving the elbow or the forearm and just in a limb semi-flex positions. None of the x-rays or any investigations are required. Any of these maneuvers could be used to reduce or feel a click while reduction. And we should always keep in mind and inform the parents about the recurrence and how to overcome it. So the second topic, which is again a very common clinical condition or a thing which we come across in clinic as an pediatric ortho, is growing pains. So when we talk about growing pains, do they actually exist? I mean, do such thing exist, or just because there's no reason we label it as growing pains? So is it a myth or a reality? And what exactly is a growing pain basically? What could be the causes of growing pain, and what is the treatment of growing pain? So this is what we are going to cover in the next couple of slides. And so actually it's not a myth, and the growing pains, they do exist. In the literature, there's a 37% incidence of this entity, and it was first described long back in the 1800s. And it can be very much severe enough that the child might be crying, or many a times it might disturb the regular routine of the child or even the sleep of the child, and along with it disturbing the entire family as well. So these are commonly seen between age 4 to 14 years of age. And again, it's the same thing, that is this actually a misnomer considering the age through which we see it? So what exactly is a growing pain? So there's no specific definition, but in fact, it's a diagnosis which can be made by excluding some of the conditions, or made by excluding other causes of the pain. And it could be just a diagnosis of exclusion at times. And it can be a quite sensitive and specific condition as well. So let's see what could be the inclusion and exclusion criteria for the growing pains. So if the pain is persistent and if the pain is over a prolonged period, it can't be a growing pain. If most of the time it has to be a bilateral pain, like bilateral tibia shin, or so it has to be probably suspected more if it's a bilateral thing. So like I said, the shin of tibia or the knee, and even the calf pains are considered as the growing pains. So articular pain should be an exclusion here because they are not part of the growing pains. And these pains, like I said, at times they could be quite disturbing, and they might also disturb the regular activity or sleep of the child. And if it's like quite a much disturbing, then we should be like thinking of some other causes. Again, the physical examination will be normal in growing pains. We won't find any significant clinical finding, or even the lab tests are normal. Even at times the vitamin D, which could probably be our savior to say that the vitamin D is less and there's a pain, can also turn out to be normal sometimes. And yes, if there are other clinical signs as well as abnormal lab investigations, then we should not label it, of course, as growing pain, and look out for more other causes. And I'll take you through some of the mimics which look like growing pains. And there could be various causes, like I said. So we need to just rule out a couple of things to label the child as growing pains. And so there are few causes, like there could be some anatomical causes like generalized ligamentous laxity or improper posture, or maybe some deformities like genu-algum, flat foot, scoliosis. They could be leading to these growing pains, or maybe they could be some pains because of the deformities around there, but none of them have actually been confirmed. And second thing would be, at times it can be a fatigue or an overactive or a hyper child, or it can also be a hyper parent, which is or a helicopter parent or a hovering parent, as we call, like small little complaint and just trying to visit the doctor, or maybe a paranoid parent to be called. So yeah, so at times it can be psychological. And yeah, many a times, particularly the adolescent kids, they could be having such pains prior to the exams, or maybe they'd want to skip some particular activity in the school, and they could come up with this. But yeah, the last paper which talks here, the pain triad, which is the headache, abdominal pain and growing pain, should always be kept in mind. And the headaches in children are very common. So even children are known to have high rates of migraines. And if the child has this kind of pain triad, it should not be overlooked or considered as psychological and should be treated accordingly. So yeah, another cause could be probably nutrition also. And recently I came across one paper that kids who lack enough sleep, particularly the boys, they are more susceptible to get growing pains as compared to probably the female children. I don't know what was the difference between the male and female child, but yeah, a lack of sleep is also one of the cause for growing pains in kids. And other associations, like I said, one of our commonest behavior is a decreased vitamin D. There could be a family history of growing pain as well. Yeah. And there could be some other causes. So for treatment, usually, I'll just quickly take you through. So the treatment is we need to stretch out the muscles, particularly the biarticular muscles, and just basic like a tender loving care, or we would say like basic management like massage or hot fomentation, just supplements and reassurance. Important is that we don't miss out some other causes or other conditions which we could actually overlook as growing condition. And I'll take you through two quick patients here. So there's a 12-year-old girl and she had a vague pain over the left knee for a while. There were no other symptoms, and after the parents insisted, an X-ray was performed, and this X-ray on follow-up did look little suspicious. And on further tests, it turned out to be an NHL. So of course, if, like I said, if the pain is persistent or it's there for a longer time, then we should certainly suspect of a mimic. This is a similar 6-year-old child and was being treated as growing pain by 2 other orthos before they met me. They already had an X-ray, and this was around like 2 months, and the pain was persistent, and now the pain was increasing. So on doing a second X-ray, I found there was a periosteal reaction, and the MRI did reveal Ewing's, but post biopsy it turned out to be an LCH. So yeah, so important is we think of the persistent pain, or if it's unilateral, and correlating lab or clinical findings, we should always keep in mind and look out for the mimics. And yes, it is a reality, it's not a myth, and with a higher prevalence, and it should be treated after ruling out other conditions. And of course, the parents need a lot of reassurance. So apart from the child, the parents also need a treatment for both of these conditions. So thank you so much.
Thank you, Chasanal.
Thank you, Mandar.
That was a very elaborate talk. Excellent about two common conditions. We'll go to the next speaker. We have a very senior pediatric orthopedic surgeon. We have Dr. Alaric, who is an honorary consultant in the Department of Pediatric Orthopaedics at the Wadia Hospital and is a consultant at the Lilavati Hospital. His main interest, his special interest is clubfoot and also about hip deformities. And hence he's going to talk to us about another common condition, which is hip pain in a child. What do we think of? Over to you, Dr. Alaric.
Great. Thank you, Mandar, for inviting me, and good afternoon to all delegates on today's webinar. This is a rather large topic, but I'll try and make it a little simple by giving a few case examples. So when we look at hip pain in children, we must understand that we must look at age-related differential diagnosis. Always rule out the presence of a significant injury, because most parents will try and relate hip pain or hip pathology to some amount of fall. We know that children fall all the time, and we must be able to differentiate a significant injury from a trivial one. When we look at the onset of pain, it's important to understand whether it's an acute onset or a more chronic, insidious onset of pain, because the differential diagnosis will change accordingly. Look for the presence of systemic illness. A sick child will have a potentially different diagnosis compared to a child who's able to walk and run despite the limp and the pain. And I think in the pediatric age group, it's very important to watch for red flags. So if we divide the diagnosis of a painful hip depending upon the age of the child, let's look at the first group, which is the infant and the toddler group from birth to 3 years of age. And I think most hip pain in this age group is usually ominous. It's usually the form of an infection, acute osteomyelitis, septic arthritis, or TB. You could have inflammatory conditions, and towards the upper part of this age group, transient synovitis is a possibility. Dr. Binoti has already spoken quite well about the recognition of infection. You must have a very high index of suspicion, and any child who has musculoskeletal pain which is getting worse with or without unexplained fever, especially with a refusal to move the affected part, along with tenderness and a limited range of motion, may be the first sign. So if you have a child like this who keeps the hip flexed, I think the first diagnosis when you try moving this hip, if it's painful, would be a septic arthritis or osteomyelitis. And it's very often that we see that surgeons tend to wait till you get a large amount of swelling or a discharging sinus, and that is really way too late to make a diagnosis of an infection. We have already talked about the Kocher's criteria. It's questionable how much role the ESR has in a place like India, where we have people with a large number of those having a high ESR. But this combination of factors is reasonably a diagnosis for an infection. We know that ultrasound is an excellent modality for diagnosis of infection early on, and I think this is a modality which is not very much utilized even now among general orthopedists. It's very important to pick up this early fluid collection with elevation of periosteum. It's positive as early in the first 24 hours, and we did a study in Warrior Hospital where we showed that adding a color Doppler, where you showed increased vascular flow around the infected periosteum, is a very easy way of picking up infection pretty early. Binoti has already shown you how X-rays are positive rather late in the course of the disease, and look for soft tissue signs rather than for bony signs to make up an early diagnosis of infection. She's also covered the infection treatment quite well, where the mainstay of treatment is in the form of parenteral antibiotics to cover both gram-positive and negative organisms. Start antibiotics ideally after obtaining all cultures. The best antibiotics are usually cloxacillin, cefotaxime, and cefazolin. Once you have pus within the joint or beneath the bone, an aspiration or irrigation of the joint may be used as a diagnostic tool and also as treatment. But usually the treatment of choice is an arthrotomy, going by the anterior approach, because you know that the posterior approach in children is fraught with the risk of AVN and post-op dislocation because of risk of damage to the blood supply. Coming to the next age group of 4 to 10 years, where you have a limping child, here you have a large variety of diagnoses which are possible. Top of the list is transient synovitis, Perthes disease, Coxa-Vara and other developmental conditions, but also chronic infection and septic sequelae are possible diagnoses. Don't forget to rule out tumors, especially osteoid and bone cysts. Transient synovitis is usually common between the ages of 2 to 10, with a peak between of 3 to 6. It's more common in boys than girls, and we know that hip or groin pain is the most common manifestation, but some children may actually complain of medial thigh pain or knee pain. They have an antalgic gait or limp, and some very young children may just present with an irritability and refusal to walk. Often children may have only limp and not much pain, and in about 50% of these children, a recent history of an upper respiratory tract infection, pharyngitis, or otitis media may be elicited. I would like to thank Dr. Taral for this video. Here you can see a boy who has a typical presentation of transient synovitis, not very painful, able to walk with a limp, otherwise comfortable, but tends to keep the hip in a position of abduction, flexion, and external rotation, because that's the position in which the hip is most comfortable because of the increased intracapsular pressure. The treatment is simple. It revolves around rest, traction, and NSAIDs. Start gentle hip range of motion exercises, restrict weight bearing for the first few days. Most children with this treatment will experience a relief of pain within a week. The range of motion gradually improves, but the limp usually persists for longer. And if you see children who have recurrent episodes of transient synovitis, think in terms of Perthes disease, because it's known that about 5% of these patients may in fact herald the early onset of Perthes disease. The next common diagnosis, of course, is quite clear from this X-ray. Here's an 8-year-old boy who has right hip pain and limp with restricted range of abduction, internal rotation, and the X-ray shows evidence of avascular necrosis, which is very typical of Perthes disease. We know the various prognostic factors which are responsible for making a decision about Perthes disease, revolving mainly around the age of the child, the range of hip motion, the stage of evolution of the disease using the modified Elizabethan classification, the grade of involvement, and the extent of collapse. And therefore, if you have a hip like this is a hip which is crying for containment, an ideal indication of age between 6 to 10 years. an early stage of avascularity or early fragmentation, a catarrhal involvement of more than 50%, and a reduced lateral pillar of 50% or more. So this boy therefore underwent a containment procedure because he was in Elizabeth stage 1B, an ideal candidate for prophylactic containment, treated initially by traction for 3 weeks to restore the range of motion, followed by varus osteotomy for containment. You must be aware of other conditions also which can cause hip pain, which are not very symptomatic. Here you have a 9-year-old girl, as you can see, who has pain only on walking long distances with a positive Trendelenburg sign. She's been having on and off pain, especially on walking long distances, more of the fatigue since 2 years. And as you can see from the X-ray, this is mainly because of mechanical cause of impingement of the greater trochanter over the iliac crest every time she walks. And she therefore underwent a valgus osteotomy with an excellent result. Another important cause of hip pain occurring at this age group is because of sequelae of septic arthritis. And again, this pain is more of a fatigue pain over walking long distances. Here's a 10-year-old boy who had a limp since walking from the age of 1. He's had a history of hip joint swelling and discharging sinus from 1 month of age, and now has pain since 1.5 years. You can see the amount of telescoping present when he walks. The range of motion is good, but he has shortening of almost 6 centimeters. The pain was there because of the early arthritis, because of the deformed head, and he underwent an Illusion of hip reconstruction, where you have a valgus osteotomy with the proximal femur, correspondingly varus and lengthening done below, and he's had an excellent result, and hopefully this hip should last him till early adulthood, when it may need to be revised to a total hip. I would be remiss at this age group if I did not mention about the risk of hip displacement in cerebral palsy. And here's a 10-year-old girl with spastic quadriplegic CP who's been non-ambulant and bedridden, now has severe pain in the left hip since 2 or 3 years, keeps the hip adducted and flexed with difficult perineal hygiene and cries incessantly at night. And when we open this hip, you can see that most of the head has been denuded of cartilage, and this hip cannot be salvaged. This child therefore underwent a subtrochanteric valgus osteotomy and excision of the femoral head, and post-op her pain has reduced markedly and perineal hygiene is much easier. We must understand that hip displacement is fairly common in CP. It's second only to equinus. Almost 1/3 of children, especially those who have severe quadriplegia, have a high risk of hip displacement. It's often missed by us orthopedic surgeons because it's a silent and progressive condition, but we know that over time they become painful in more than 50% of patients. The paradox here is that it's difficult to detect, but easy to manage if picked up early, but easy to detect, but difficult to manage in the late stage. The risk, as we've already shown, is highest in the children who have spastic quadriplegia, what we call a GMFCS type 4 and type 5, but it can be present even other types of CP, especially athetoid and even hypotonic. So therefore, this boy who's 8 years old, who has a hip displacement of more than 50%, underwent a medial open reduction with a varus derotation osteotomy and femoral shortening, fixing with a proximal femoral plate, and a good result because it has been picked up in time and treated well so as to ensure a good result. Don't forget other causes of painful hip, especially a child who complains of pain in the night, which is relieved dramatically with NSAIDs. When you have a thickening of the cortex, as you can see here, that's a very definitive diagnosis of an osteoma, where you can see a nidus surrounded by very reactive bone. This is in a very accessible site, but very often it occurs in inaccessible sites which are relatively difficult to reach, such as the medial femoral neck or even the pelvis at times. This can be treated very easily either by a CT scan guided drilling or by a radiofrequency ablation, depending upon the cost that the parents are willing to undergo and the training of the treating surgeon. Coming to the final age group of the limping adolescent, here you have some very specific entities, especially the slipped epiphysis, residual hip dysplasia because of DDH, chondrolysis or infection. Here's an example of a boy who you can see walking with an externally rotated gait. And this child may not have much pain, but definitely has limitations of range of motion. And this feature of an outgoing gait is very typical of a slipped epiphysis. We know that you have an external rotation deformity, and an important clinical sign is a positive Dremen's test, where there's obligatory external rotation when you try to flex the hip because of the posterior displacement of the femoral head and the resultant retroversion. It's important to diagnose this early. The line that we use is called the Klein's line, where you know that in the normal hip, the line will intersect the lateral aspect of the femoral head, whereas in the slipped epiphysis on the AP view, the femoral head will lie medial to this line. On the lateral view, it is often very well diagnosed, and here you can see a posterior medial slip of almost 30 degrees. If you pick this up in time, it can be treated quite well with an in situ pin fixation, as you can see in this 13-year-old boy. But more often than not, it's often missed, as you can see in this boy who had dull knee pain and limp. The diagnosis of slipped epiphysis was not so apparent. He was, of course, when diagnosed, advised an urgent in situ fixation, but refused, went home, tripped and fell in the bathroom, and now presents with a grade 3 slip with a slip angle of almost 82%. And this is almost impossible to fix with an in situ fixation. He therefore underwent a very large surgery in the form of a surgical displacement, the dislocation of the femoral head, where you strip off the periosteum and create a periosteal flap, and then proceed to do a realignment of the femoral head, as you can see, over the reduced neck, which is now vascular, as you can check with the blood flow, and then fixed with a K-wire and a cancellous screw. A final case where of a child who adolescent who of limp and pain, especially on walking long distances, fatigue pain because of a Trendelenburg lurch, occasionally difficulty in squatting and sitting cross-legged, as you can see in this adolescent, and impingement pain because of flexion, adduction, internal rotation. This is the X-ray where you can see that the left is subluxated, where the acetabulum is shallow and dysplastic. She underwent a femoral derotation and varus osteotomy combined with a triple pelvic osteotomy. At a follow-up of 5 years, you can see there's excellent containment and coverage, and this is an important cause of hip pain in the adolescent age group. So to conclude, we know that many conditions can cause a child to have hip pain. Approach each patient in an organized fashion. Differential diagnosis should be age-based. A good history will provide guidance for a proper workup. Use investigations judiciously and appropriately, and provide a treatment algorithm based on a very intricate decision matrix. Thank you very much for your attention.
Thank you very much, sir, for this comprehensive review. We'll now quickly go to the to a very eagerly awaited section of this webinar, which is the case discussions. We have two very eminent pediatric orthopedic surgeons for this. The first speaker will be Dr. Taral Nagda. He is a very senior consultant pediatric orthopedic surgeon and the department coordinator at the SRCC Children's Hospital. He is the head of the Jupiter Cerebral Palsy Clinic. And along with that, with him, we have Dr. Shah, who is also a consultant pediatric orthopedic surgeon at the SRCC Children's Hospital and the Bhatia Hospital. Over to you, sir, for making it an extremely interesting session.
So the seniors will give way for the younger people. So I would ask Avi to start first, and then the second presentation I will do. Avi, please start here.
Yeah, thank you, sir. I'll just
all the other panelists also to start their videos, keep their videos on so as to be more interactive.
Thank you, Dr. Mandar and Taral, for inviting. And I mean, after today's amazing lectures, I don't think any of these cases will be googlies or dusras anymore, but let's see. So overall, I would say like all the pediatric orthopedic cases, no child is the same. They always make us use different parts of the brains at different times, which we don't want to use at certain periods, and always just stay open-minded, and sometimes things aren't always what they might seem to be. So the first case, this was a 6-year-old female child who presented to me. So just a brief background, she had a history of a trivial injury to her left elbow around 1.5 years back. The parents don't know what exactly happened. She just complained of a little bit pain and then started slowly having restricted movements. During that period, she has seen around 4 or 5 orthopedic surgeons. She had multiple x-rays, which were all deemed normal, and just always advised analgesic and rigorous physiotherapy. So I'd just like to ask all the senior faculty who are there, like, what would their thought process be if the child had presented to you on the first day like this? Sir, you're muted.
I would like to ask, we'll start with Rujuta. And Rujuta, if you unmute and...
Yeah, so I mean, if you tell me that there's a 6-year-old child who's been going around for 1.5 years with a fixed flexion deformity at the elbow, and you can see the pictures that nothing much has, I mean, even her range doesn't seem to be really much, although these aren't the ideal way to demonstrate movement. I would definitely think if it's following trauma, then I would definitely think anything from lateral condyle to elbow dislocation to malunited Montegias could be present. But if the trauma you say is not significant, so the really history of the way the trauma has happened and what was done after it is not there, and if it was a very trivial trauma, then very likely in our country that everything is attributed to trauma, but something else is going on, and this could be anything from a villonodular synovitis to reasons for a stiff elbow like myositis. So you need to define the history really clearly as to why she's stiff since 1.5 years.
Lovely explanation, ma'am. So as how ma'am said, so these were her x-rays, which were always set to be reported normal, and she kept being sent to physiotherapy and continuously giving analgesics. But the parents again used to keep complaining that every time we move her elbow, she used to get pain. So when she presented to us, I got bloods done. As such, all her blood investigations were normal. I advised an MRI because 1.5 years of no movement in a joint rings alarm bells in my brain. So the MRI showed severe synovitis with some, which was completely engulfing the entire elbow joint, and it was reported as a PVNS. As per this thing, we did a biopsy. The biopsy said it is PVNS. Still, the parents wanted a second opinion. The histopath slide again was sent to Tata Memorial to get a second opinion. That also said it is PVNS, and all the cultures, gene expert were also sent, which were all normal. So we went ahead and planned a total synovectomy of her elbow joint. But when we opened her joint, her synovium did not look like the typical PVNS elbow joint, which you would normally see, the reddish bluish hue which you would see. It looked like a mushy and fluidy tissue which came. So I sent it again for a culture, but initially nothing came positive. But at her 6-week follow-up and the 6-week final report, it turned out to be tuberculosis. So the child started on a journey thinking of PVNS, ended up in tuberculosis, started with AKT. So just a reminder that whenever you think of a biopsy, always send cultures. TB can, especially in India, can come as any picture, and in consequence, elbow can look like anything. So this is her X-ray now at around 9 months. She's already on AKT. Can see some changes near the radial head and near the capitulum, but nothing sinister. But and at around this is her at 10 months, so she has very good range from at least what she was. She's active, back to school, and as such, she is happy. So our senior colleagues, like if she would have presented you initially on day one before this entire 1.5 year period, was there something different? Would anyone have helped to pick her up much earlier?
So I was just about to ask you that when you gave us a presentation of the slide, you didn't mention anything about the blood counts and all that, and whether the elbow was warm or no. So I think a lot of difference it makes when you examine the child personally yourself, and whether there's any pain associated with the range. So these three things with a very dubious history of trauma in our country, I think your TB should go up high on the list. But when you, on the other hand, when you see going in at 1.5 years, you tend to change your order of listing what things are, kind of the most probable diagnosis. But yeah, TB can mimic anything, and it's very known in our country, so one should always keep it at the back of my mind. If you have a complete information, then it definitely helps the person analyze the case better and think in terms of a better diagnosis.
The interesting thing about her is she never had a swollen elbow. It was never red, never any history of fevers or anything. Only time she used to get pain was when the family used to try and stretch her elbow to kind of make it straight with the therapy. And previously, whenever she was seen by other surgeons, no one ever had got any other investigations other than X-ray. They used to see her, see the X-ray, and send her home. So hopefully this now keeps everyone's mind that keep an open mind and see into other things. Don't just send the child away. So I'll just start with the second case.
Can I just add, we have monoarticular synovitis, which has been chronic and painless. We of course have a differential diagnosis, and you have mentioned two conditions. It could be tuberculosis, chronic inflammatory synovitis. It could also be pigmented villonodular synovitis. One more condition which I want to add now, which I have seen two cases, and there is great work done by one doctor in MP on this, is leprosy synovitis. And this is something which is coming up in a big way in rural India. All of us talk about tuberculosis and resistant tuberculosis, but resistant leprosy and resurgence is in a big way. So keep that in mind. If you see a child who has unexplained neuropathy or unexplained synovitis, add that to your list and send for appropriate culture and biopsy for the same next time you have a case.
Thank you, sir. So I'll just go on to a second case. There's a case of a dubious limb. So this was at the height of lockdown, where most consultations were done by these videos sent over by families to doctors. So this was a 15-month-old child who was just walking with a limp like this at home. So the family, on and off, they said the child had low-grade fevers and gave her ibugesic. Otherwise, she was absolutely fine. So this was the video which they had sent over to their pediatrician, who at that time, looking at the video, just said it is transient synovitis, advised the family ibugesic syrup, and that's it. But the family didn't notice much change. When they continued after a couple of days, I would say exact 5 to 7 days, the mother especially noticed a swelling again on the same side on the knee now. But she still was walking in the same manner, similar history, again on and off, sometimes a fever. That time they saw an orthopedic surgeon in their local area who advised a blood test. So the WBC counts at that time were around 14,500, nothing too high, but he did not see the differential count, which said neutrophilia. CRP was nothing very significant, around 4. ESR was 45. He advised an ultrasound scan, which showed a synovial thickening, very, very minimal fluid. And he advised the surgery arthrotomy, stating it is a septic, he felt it is a septic arthritis, and advised an arthrotomy at that point. The family were still not very keen, or well, they did not still trust the surgeon that much. But the faculty now, if a child is now presenting like this, what would be their thought process in their mind?
Can you have some things to share on this? Hip pain and then knee swelling and minimum synovial thickening.
So as the last case, I think Cox hip should always be kept in mind because of the chronic history and not very sick looking or toxic child with long duration history. Knee swelling sometimes can come up in hip pathologies as a reactive, so we really need to have a detailed examination. But if it is also having a synovitis, then again inflammatory condition to be kept in mind. So further radiological investigations are a must. An X-ray and maybe an MRI would help us to know, and also more detail about exactly the clinical examination, the hip range of motion, the limb length, and everything will help us to make. But I would keep again low-grade infection in mind and inflammatory pathology.
So one thing I want to ask Mandar, what would be your first investigation? Would you prefer ultrasound or MRI? It's always a dilemma in what to go for.
I have a very low threshold of getting an MRI done, because I have burnt my fingers by doing an ultrasound which is non-diagnostic, and then we are stuck. An MRI gives a much better information than an ultrasound. So I'll probably get an MRI done rather than an ultrasound. That's just my personal opinion, but that is what I
There is a recent JBJS review of 2020 where they have recommended that now current trend is to have an MRI a must, especially in a acute septic arthritis or an osteomyelitis. Within first 24 hours, it is a must to do because that, as he said, changes the management completely in many cases.
Thank you so much. So, well, the family weren't convinced, and this is when they came and shown me. So, the hip range was was full, absolutely painless. The knee, there was effusion. The child lacked around 20 degrees of a terminal extension, but otherwise the range was completely full. There was mild, very mild redness and local rise of temperature, but nothing very sinister. This was how the child was moving about, and she seemed, other than the limb, she seemed non-toxic and otherwise pretty happy. Only time she cried was when you tried to examine her. So I did think of getting an MRI, but at that point, the family, because of finances and a lot of other issues, so I just repeated an ultrasound and I screened even the hips. So it showed she had synovial thickening in all of her joints, in both her hips and the symptomatic knee, as well as there was some thickening even in the non-symptomatic knee. So at that point, I kind of did not want think about arthrotomy or septic arthritis because it not fit in as per the talk. And if I would have heard Dr. Vishwanathan's talk earlier, this would have made my work very easy. So I just went on for a biopsy. The biopsy just said it is synovitis, and as such, all cultures were negative. The blood test pretty much were negative. All her ASO and all was still negative. But taking a consult with rheumatology colleagues, it turned out to be a very early onset type of JIA. And she did very well with just naproxen. And now she's been started on methotrexate as well. But otherwise, this child did very well and ended up avoiding and maybe an unnecessary surgery at that time. Thank you.
Anyone, would have saved the biopsy. Of course, retrospect we would think, but at the same time, Abhi, there are a lot of cases where rheumatologists treat it as synovitis, and down the line when it doesn't respond, 3 to 4 months down the line, you do a biopsy and then it turns out to be tuberculosis. So I think what I would do is, if it looks like a rheumatological or inflammatory process, start on treatment. But if it doesn't respond, rather than going to a higher line of treatment, it's worthwhile doing a biopsy and a culture, and then progressing ahead.
I'd just like to ask everyone regarding the biopsy. I mean, what would everyone thought? As you said, first just start the treatment and then let's see, or would you think let's do the biopsy, let's rule it out completely, and then start the treatment?
So another thing, Taral, what I would like to say is that when you are really doing something by exclusion and JIA is coming to your mind, a simple X-ray also could be repeated if it shows you juxta-articular osteopenia, which usually shows up only after 4 to 6 weeks if it's a disease in evolution. You do have a clue. So then you go in with a more focused view in the biopsy. So once you're looking for JIA, you probably will find JIA versus a TB where you will obviously pass or something over there.
So previously, I remember a lot of rheumatologists used to do a bone scan in case of a synovitis, because if that shows polyarticular increased uptake near the joints, then that would go in favor of JIA. And I remember at Induja in past doing having several cases where there is a monoarticular synovitis, a bone scan is done, they pick up multiple joint uptake and then label it as JIA and treatment accordingly. The flavor of today investigation is whole body MRI, which is possible to do nowadays in a very short time. So in a monoarticular synovitis, the rheumatologist will nowadays always do a whole body MRI, which will pick up more joints which are not clinically palpable, those which were not tender, but actually were involved in the disease process. And that sometimes differentiates between a monoarticular synovitis and polyarticular, and that may help you to avoid a biopsy. Can we go to the next part, Mandar? Okay, so again, I want to discuss something which is not very often discussed in orthopedic circles. These are cases of osteomyelitis, but there is no osteomyelitis. So something of a diagnostic dilemma. And I really did not know much about this condition just few years back, but last 2 years, and especially last year, there has been a lot of reading and understanding and wisdom which has happened. So quickly, a few cases. This is a 5-year-old child with right leg pain. She had a nasal polyp and pain over the right leg and fever on and off. So these were the symptoms. And when I saw this child referred by a pediatrician, there was a swelling on the right leg with no warmth, but there was a tenderness. And when we took the X-rays, it showed periosteal reaction. So I hope Chetan was here, but when you see a child with pain, fever on and off, and diaphyseal involvement and periosteal reaction, So first thing which wings your mind is Ewing's. So, is this tumor, is this infection, or is this something else? And with that, of course, we went for further investigations. The MRI, again, MRI, they will give you the diagnosis and not give you the diagnosis. So, they will say there is a marrow edema, periosteal reaction, and they will say that, correlate clinically. So, ball is back to your court. Is it tumor, is it infection, or something else again? So, with this, with several thought process and consultation, we spoke to the family, and we initially got a needle biopsy done. This was done by an oncology unit, which was completely negative. And the oncology unit requested us to do an open biopsy. And this open biopsy turned out to be a suspicious material. This was also sent for on-table frozen section, which did not reveal much. But this was, sort of a material obtained. We did saucerization. And when we sent for histopathology, it showed necrotic cells, inflammatory cells, and no tumor. This was the pathology report. And I said, let's wait for the culture report. So aerobic culture, there was no growth. Mycobacterial report, there was no growth. Now, what do we do in this situation? Should we, I can, imagine your situation, Avi, where you have a demanding family. You have done everything, done biopsy second time, biopsy and then complete excision, and you are waiting for culture report and nothing is shown. So this was the period we were sitting on and nothing was coming through. And, that was the dilemma. Second case, 8-year-old girl with pain in the left knee, gradually progressing, night pain, but no fever in this case. And you can see that this is where she has pain. These are the X-rays, and you can see there is a sort of some lesion, near the tibia. So, there is a suspicion. Is this infection? What is happening here? Next thing, of course, you want to do is to do further imaging, as Binoti said, and get MRI done. So MRI shows that, there is increased uptake, there is synovitis, and there are some erosive areas in the cortex which are seen. So these are few, cuts of the MRI. And again, the, dilemma is, what is this? Is this an infection? If it's an infection, is it bacterial infection or tuberculous infection? Should we do a biopsy? What should be done? And you can see the CT scan here. You can see there are lytic areas on the posterior side. So we thought that this is the area which is a problem area, and let's go and do a biopsy. So we did a CT guided biopsy, a needle biopsy from that area. And this again showed few necrotic cells. The same script. There are different movies, but the same script, same dialogues happening here. And when we do culture, we send for all the cultures, and all cultures are negative. And the dilemma here was, again, should we start on antibiotic, AKT, and what should we do? Third case here, 5-year-old child with right hip pain. Again, no fever, there is a pain on and off, coming and going. So this is the typical story. The pain comes and goes. there is no pain for 4-5 days, suddenly there is pain. When there is pain, child cannot walk. When there is no pain, the child is running around. So that's the typical picture you will see here. Blood investigations, raised ESR, raised CRP, and this was the X-ray. And MRI shows that there was sacral edema. So you can see that on the sacrum there is increased edema and some disruption of the bony tissue which is seen around, but the joint was not involved. So again, this case, what should we do? And naturally we went for biopsy first. So you can see biopsy was done. Same, different pathologies, different labs, but as if they have copied and pasted the report. Inflammatory cells and no malignancy. Culture again negative. And what is the common point in this story is all of them had bone pains, which are on and off. All of them had ESR, which was more than 30. There was plus or minus fever. So some had fever, some didn't. In all of them, biopsy was inflammatory and culture was negative. So what are we dealing with here? So we discussed these cases. One more thing again in common was with a rheumatologist. And, the tentative diagnosis we came to was chronic recurrent multifocal osteomyelitis. We came to this diagnosis because this is mentioned in orthopedic literatures. But this may not be chronic. It may not be recurrent. It may not be multifocal. And lastly, it may not be osteomyelitis. So the current nomenclature is chronic non-bacterial osteitis. That's what we call it as CNO. And the long and short story of this is, after reviewing few of the literature, this is the summary I am giving you. It's a relapsing autoimmune bone disorder. Like how we have autoimmune joint inflammation, which we call it inflammatory synovitis. This is the autoimmune bone inflammation. Radiological imaging is suggestive of osteomyelitis. Approximately 400 cases have been reported so far. I am sure the number is very high. This is like corona report. The actual number is very high, what is reported, and investigated is less. So I feel many more are actually present. Typically 9-year-old plus child, a female, but we've had boys also, and they have inflammatory signs and symptoms, remissions and relapses, but they are non-progressive. See, if it was a tuberculosis or a malignancy, it would progress over a period of time. So if you see this children's MRI 6 months back and now without any treatment, there is no progression, and that is something which is a diagnostic clue in these patients. Etiology, it's an inflammatory origin. One really does not know if this has been caused by some unknown microorganisms. These are misdiagnosed as bacterial osteomyelitis, and pain, which is insidious and goes on and off. I think that's the symptom. Radiology would suggest areas of inflammation. There may be synovitis. There may be erosion of the bones. Lytic sclerotic lesions may be seen, and that's why we mistake this for osteomyelitis. The investigation which is suggested now to diagnose this is whole body MRI. Again, this is a diagnosis of exclusion. Whenever possible, a biopsy should be done because this could be tumor such as leukemia. It could be infection, so culture and biopsy should be done. Is biopsy necessary? So there is something known as Bristol's criteria. So if you have a child which fulfills this Bristol criteria, which means presence of bone pain and typical radiological findings with CRP less than 30 and high ESR. Okay, so that's a Bristol criteria. If that is present, you can treat this just with anti-inflammatory medications. If the child does not have very acute symptoms, one of the tests I have found is to treat these children with naproxen. So if you have a bone pain which looks like a chronic non-bacterial osteitis, but you are not sure, and if you don't want to do biopsy, or in Avi's case, the family doesn't agree to any more surgeries or investigation, just give them a short course of naproxen. And if there is response to naproxen, like osteoblastoma, almost it is diagnostic of this condition. What if naproxen doesn't work, or if you give naproxen and if the pain comes back? Recently, people have started using bisphosphonates. So, that is a brahmastra for all rheumatologists. For every condition, I have seen, they want to use bisphosphonate as a treatment. but we leave it to them. Some people use colchicine, and in one of our patients, they had to use the immune treatment. So this patient, which I spoke about, he responded initially to naproxen, but later on, had pain again, had a pulse steroid treatment, and finally he's been considered for anti-inflammatory treatment. So I want to thank our fellow Varun and Monica, who are working at Jupiter and SRCC, and Jaideep, of course, who was the main workhorse behind working up these cases, and rheumatologist Dr. Raju Kupchandani and Vijay Vishwanath, for allowing us to know about this condition, making us aware of it, and helping us to treat these patients. So take-home message is, it's a culture negative, relapsing multifocal osteomyelitis, primarily affecting children and adolescents. It will, of course, come as a very important office practice knowledge, because any of these patients could come into your clinic anytime, and you should know about it. And most important thing, point number 4, treatment with antibiotic has no effect on the clinical course and or outcome. So next time you have a culture negative osteomyelitis like looking condition, don't start that patient on IV or oral antibiotics or AKT. That's a common practice and should not be done. And finally, a big thanks to Mandar for organizing this Suburban Orthopaedic Society, Satish Mutha, Ashok, and Neeraj, because I believe that the wisdom has to change today. People used to say, eyes do not see what mind does not know. That's what Avi said. But I want to say that eyes don't know, eyes don't see, and mind does not know what is not covered in a webinar like this. So now our eyes know, eyes can see, and minds know, because webinars like this are organized. Thank you very much.
Thank you very much, sir. We come to the end of this excellent webinar. I would also like to thank our chief sponsors, Janssen, who have given an educational grant to MSOS. I would like to thank the entire team of MSOS, Dr. Satish Mutha, Dr. Ram Prabhoo, sir, who unfortunately could not attend the webinar today. And last but not least, I would like to thank all the faculty who have spent half their Sunday with us for giving their excellent talks over the last 3 hours. Over to you, Dr. Satish Mutha, for your final words.
Mandar, thank you for this beautifully curated webinar. It was really, really informative. I did learn a lot of things today, something out of the book, right from how to make a patient comfortable and what strategy to adopt, as said by Swapnil, to club foods, to deformities, to the rheumatic aspect, and this last thing, the CNO, which was really interesting. So overall, I think me and most others who are not established pediatric orthopedic surgeons will be a lot more comfortable in our OPDs and maybe a lot more astute in picking up cases and managing them. Thank you, Mandar. Thank you, the entire team, for spending time on this Sunday and conducting this really informative webinar on behalf of MSOS. Neeraj tells me that more than 1,200 people have logged in, which is really a nice thing. And hope we have many more such webinars in the future. Thank you, Mandar. And thanks to everybody else. Thanks, Atul, Rujuta, Dr. Avisha, Teja, Taral.
Thanks to OrthoTV for Neeraj and Ashok for all this web support.
Thanks. Neeraj, are you around? Neeraj? I think Neeraj must be busy with
okay, bye-bye.
Webinar, so let's sign off ourselves. Okay? Bye and have a great weekend.